iBRA-Net and Memory Fold Academic and Research Committee Research Day. Hopefully this will be a really good day. We'll hear about some of the work that both the iBRA-Net and the MFAC are doing, and this is a fantastic chance to get involved as well. I'd like to draw your attention from the very beginning to the fact that we're looking for trainees to help with our comms, and there are other roles as well available within the iBRA-Net, so please get involved. Please register on our website for our newsletters. And yes, hopefully this will be a really good day. And now I'm going to hand over to Jenna, who's going to be chairing the first session.
Shelley. So yeah, again, on behalf of the Memory Fold Academic Committee, I'd also like to welcome you today. And we're going to kick off the morning with our iBRA-Net study updates. So in fact, actually, I'm going to hand back to Shelley for the first session, which is rapid updates. And Shelley's going to talk to us about the progress of Anthem and breast bra.
Fantastic. I'm going to try and share my screen. Okay. Tahir, can you stop sharing yours, because I can only see your presentation at the moment. I don't know if Lena or Lucy, you might be able to help.
To hear, you need to stop sharing.
There we go.
Cool, fabulous. Right. Right, can you see my slides?
We can, Shelley, thank you.
Fabulous, brilliant. So thank you for this opportunity to update you about Anthem and BEST-BRA, which are two iBRA-Net studies that are currently ongoing. So as we all know, implant reconstruction is rapidly evolving. We've had the introduction of mesh that has allowed us to put the implant under the muscle, and then more recently, wrapping the muscle in mesh and putting it on top of the muscle. And although many of us think that prepectoral reconstruction is a really good idea because it avoids animation, it potentially causes less pain, it may give better cosmetic results. We did try this several years ago, and this technique was abandoned because the outcomes were so poor. And if you look at the evidence that we have so far from the iBRA and the pre-BRA studies, what is particularly striking is that all of the outcomes, be that infection, implant loss, readmission or reoperation, in iBRA, which is predominantly subpec with mesh, and pre-BRA, which is prepectoral with mesh, are essentially the same. And also the 18-month patient-reported outcomes. If you look at satisfaction with breasts at 18 months, there is practically no difference in satisfaction with breasts at 18 months in pre-BRA and iBRA. So what we really need is a randomized trial comparing the two techniques to determine what is the most cost-effective and clinically effective type of implant-based reconstruction. So BEST-BRA is an external pilot with an embedded quintet recruitment intervention, which will establish whether it's feasible to undertake a large-scale RCT comparing the techniques. The primary outcome of our pilot study is recruitment, but our secondary outcomes mirror those of the future trial. And the aim is that if the pilot is successful, we will just roll it into a main study. And the secondary outcomes are satisfaction with the breasts at 3 and 12 months, pain scores, surgical complications, additional surgery, cosmetic outcomes at 12 months, and health economic outcomes. Women who are going into BEST-BRA must be 18 years or over. They must need a mastectomy for breast cancer or risk reduction. They must want an immediate implant reconstruction, and their surgical team must consider them suitable for either pre or subpectoral reconstruction. We're excluding women having delayed reconstructions and those having revisions. So how are we getting on? Well, we opened our first site in August 2021, and we've also, like everyone else, been affected by COVID. So far, we've opened 8 centres. We've got 3 more sites in setup, and 12 sites are at the expression of interest stage. So far, we've recruited 2 patients from 2 sites, so 1 from St George's and 1 from North Bristol. This is an ABS badge study. We're still suffering a bit from COVID because not all centres are back doing implant reconstruction again, but we're planning to have the feasibility study open until January next year. And as I said, if it's successful, we'll roll the funding into the main study. If you're interested or want to get involved, please email the Best Bra study email or email me, and we can arrange to have a chat about the study if you want a bit more information. So that's Best Bra. Then we're on to Anthem. Anthem has come about after the combined analysis of TEAM and iBRA-2 showed that therapeutic mammoplasty was potentially a better option for many women, as the rate of complications was significantly lower. But there are no studies directly comparing the techniques, so we designed one. So Anthem is another feasibility study, determining whether it's possible to do a large-scale study comparing the clinical and cost-effectiveness of oncoplastic breast-conserving surgery and mastectomy plus or minus immediate reconstruction in women who are not suitable for simple breast conservation. It's got 4 phases: a national practice survey, a prospective multi-centre cohort study, a qualitative interview study, and hopefully finally a large-scale prospective cohort study. So we're looking at including women who are 18 or over with invasive cancer or DCIS. They must be suitable for and offered both a level 2 oncoplastic breast conserving procedure, either a TM or a local perforator flap, or a mastectomy with or without reconstruction. It's not a trial, so both options don't have to be offered equally. You may say you could have this or you could have that, but I would recommend that's completely allowed. We're excluding women who are suitable for standard breast conserving surgery and those having level 1 procedures. And we're also excluding women having oncoplastic breast conservation for other reasons than to avoid mastectomy. So those women who have got potentially small tumours in very large breasts who are having therapeutic mammoplasty to avoid the complications of radiotherapy, for example. Our feasibility outcomes are whether we can identify and recruit this group of women who aren't suitable, who are offered oncoplastic breast conserving surgery as an alternative to mastectomy, and the proportion of patients having each of the procedures. There are also exploratory outcomes looking at complications at 3 and 12 months after surgery in comparable groups, patient-reported outcomes, and to see whether the BreastQ questionnaire, the core cancer module, is appropriate to use in the main study. We're getting on quite well. We've got 32 units open, and 5 have opened since January. 24 units have actively recruited, and we've got 208 women so far in the study. We're going to extend recruitment until December because we've had ongoing COVID delays, and now we've got a large number of high volume units open. We really want to capitalise on that. This is our recruitment graph, and as you can see, the blue line is what we expected, and the orange line is where we are at the moment. We are slightly above where we want to be, but most of the women, as you will see later, are in the therapeutic mammoplasty group, so we really want to increase recruitment in the other groups. This graph shows the recruitment by site, and as you can see, Newcastle is our top recruiting site, but we've got Tayside, Aberdeen, Liverpool, Worthing, Ipswich and Bristol all recruiting really, really well. And some of the lower recruiting sites have just literally come on board, so watch this space. In terms of what people are actually electing to have in our 208 patients, as you can see, the vast majority, more than 2/3, are having oncoplastic breast conservation, but 80% of these are having therapeutic mammoplasties, with a much smaller percentage having perforator flaps. Then just under 1/3 are either having mastectomy with or without a reconstruction. And most of the reconstructions, almost, well, 60% are implants and 40% are DIAPs. So please, please, please keep recruiting to Anthem. We will keep going until December 2020 and hopefully have some really good information. But thank you all for your help with both the studies, and thank you for listening. If you have any questions or would like to participate in any of these studies, please get in touch. Thank you. I will now stop sharing.
That's brilliant. Thank you, Shelley. It sounds really, really exciting. Right, so our next speaker then is Mr. Beck Kim, who is going to update us on the MFAC study and its national practice questionnaire. So for those of you that don't know Mr. Kim, he's a consultant oncoplastic breast surgeon at the Leeds Breast Unit. He's a member of the Association of Breast Surgery Academic and Research Committee and is currently leading on the delivery of the MFAC study.
Thanks very much, Jenna. I'll just share my screen. Okay. Can you see the slides?
Yes, we
We
can.
can, thank you.
Yes, thank you, Beck.
I'll try and make it into full screen as well. I think let's try. Does that show up okay?
Perfect.
Great, okay. So thanks very much for inviting me to present the MFAC study National Practice Questionnaire results. MFAC study is National Study of Management of Breast Cancer, Local Regional Recurrence and Oncological Outcome. Breast cancer local regional recurrence is defined as ipsilateral breast cancer recurrence within a conserved breast or in the chest wall or skin after mastectomy, and can also occur in regional lymph node stations. We know that with advances in oncoplastic breast surgery techniques, breast conserving surgery is being increasingly performed with relatively low 5-year local recurrence rates. However, we know that with longer-term follow-up, 10-year cumulative incidence of local regional recurrence is as high as 8%. Currently, there's lack of high-quality research data and guidelines on how we should manage this patient group, and also that there's concerns that local regional recurrence is being underreported in the UK, was highlighted by the NABCOP audit data from 2020. There's clinical uncertainty about how to optimally manage this patient group, as well as their prognosis. The current knowledge gap include patterns of patient presentation, association with metastatic disease, optimal management strategies, and what the patient prognosis is. This was identified as a research priority at the 2019 ABS Gap Analysis meeting. We therefore set up the MFAC study, and first phase was the National Practice Questionnaire. Our aim was to evaluate how breast MDTs are managing this patient group. We opened the survey for 6 months between February and August 2021. We set up scenario-based questions to explore MDT approach, especially with regards to preoperative investigations, type of breast and X-ray surgery based on common clinical scenarios, and what the systemic treatment choices were. As you can see from the UK map here, we had even geographical distribution, and in total 42 UK breast units participated, and in total 822 MDT members participated in the MPQ. And as you can see, we had even distribution between surgeons, oncologists, pathologists, and radiologists. This bar chart here shows the stated number of patients diagnosed with local regional recurrence in the participating units per year. And what you can see is that for most units, they're treating at least 5 patients per year, either with isolated local regional recurrence or with local regional recurrence with associated distant metastases. With regards to diagnosis and staging, all units said they always perform axillary ultrasound scan when patients are diagnosed with local recurrence after previous conservation surgery and sentinel lymph node biopsy. If the patient had previous axillary node clearance, 95% would still perform axillary ultrasound scan. With regards to staging investigation, 95% of units said they would always perform staging if the local recurrence was in the same breast quadrant and the same molecular receptor profile status. If the tumor was in a different quadrant and had different molecular receptor status, 64% of units said they would always perform staging investigation. Staging investigation modalities varied, so 95% would perform CT, chest, abdomen, and pelvis, 12% would perform PET-CT, half would perform blood tests, including tumor markers. Bone scan was selectively used in 31%. This is surgery to the breast. So we asked two questions. To your left, we asked whether units would opt for repeat breast conserving surgery if patient had previously had conservation surgery and radiotherapy. As you can see by the bar charts here, 60% would never offer repeat breast conservation surgery in this situation. Almost 40% would occasionally offer repeat conservation surgery, and 10% would usually offer repeat conservation surgery. We then asked whether units would offer repeat breast conserving surgery if the patient had previous conservation surgery without radiotherapy. In this situation, almost half would always offer repeat conservation surgery, and 40% would usually offer conservation surgery, with the remaining 10% occasionally or never offering repeat conservation surgery. With regards to surgical activity management, 95% of units would always offer repeat sentinel lymph node biopsy for local recurrence after previous conservation surgery and sentinel lymph node biopsy. However, the use of preoperative lymphoscintigram varied. So 69% would offer repeat sentinel lymph node biopsy without lymphoscintigram. Quarter would offer repeat sentinel node biopsy with lymphoscintigram to look for any aberrant lymphatics that might be outside the ipsilateral axilla, and very few units would offer clearance or no axillary surgery. We then asked the units, if you're unable to detect sentinel lymph node on repeat sentinel node biopsy, how do you proceed? Majority of units would offer 4-node axillary node sampling, with small number of units offering clearance or no further axillary dissection. For radiotherapy, we asked two scenarios. If patient had mastectomy skin flap invasive recurrence after wide local excision or local clearance with clear margins, what units would do? And 90% of units would always or usually offer chest wall radiotherapy in this situation, and 10% occasionally or never offering chest wall radiotherapy. We also asked for units, if you offered repeat breast conserving surgery after previous conservation and radiotherapy, would you offer repeat breast radiotherapy? And 83% would never offer repeat breast radiotherapy in this situation. With respect to chemotherapy, we asked a specific question. So we gave a scenario of a patient who was 65 years old, fit and well, who had mastectomy and sentinel lymph node biopsy 7 years ago for node negative, grade 3, EL positive, HER2 negative invasive ductal cancer. Patient received adjuvant chemotherapy and then completed 5 years of endocrine therapy. The blue bar chart shows that patient presented with 1.5 centimeter skin flap recurrence, which was resected with clear margins, no positive lymph nodes, and same molecular receptor profile, EL positive and HER2 negative. In this situation, most units would occasionally or never offer adjuvant chemotherapy. And if you look on the orange bar chart, for the same recurrence tumor size with clear resection margins, but this time one node was positive in the axilla and the same molecular receptor profile. In this situation, more units were inclined to offer chemotherapy. As you can see, over 20 units would usually offer adjuvant chemotherapy in this situation. And lastly, same skin flap recurrence tumor size with clear resection margin, but this time the tumor was triple negative, as shown by the gray bar chart. In this situation, most units would always or usually offer chemotherapy. Therefore, the decision to offer chemotherapy in this setting is dependent upon the tumor molecular receptor status. We also explored variation in adjuvant treatment to treat local regional recurrence if patient is currently on endocrine treatment for primary breast cancer. The patient had local recurrence for EL positive HER2 negative cancer after mastectomy and sentinel lymph node biopsy 3 years after diagnosis, i.e. while still on endocrine therapy. All units said they would switch endocrine therapy. However, there was variation in decision-making, as 67% would consider chemotherapy, 29% would not offer chemotherapy. So MFAC study is in the second stage now as a prospective cohort study. Our aim is to establish prospective cohort of patients diagnosed with local region recurrence with or without distant metastasis in order to describe and evaluate current management prognosis. Our aim is to follow patients up for 3 and 5 years to determine oncological outcome and evaluate potential prognostic factors. Our aim is to also stratify local region recurrence as either true recurrence or new primary breast cancer and explore if this affects oncological outcomes. Our study endpoints are primary endpoint of disease-free survival following local regional recurrence resection. This will be stratified according to type of surgery performed for the primary breast cancer. This hypothesis based on the early breast cancer trialist collaborative group meta-analysis on the effect of radiotherapy. Our question is that, do patients who present with local region recurrence after conservation surgery and radiotherapy have better subsequent prognosis than patients initially treated with mastectomy? Our secondary endpoint is a progression-free survival and overall survival in patients with local region recurrence with or without distant metastasis presentation. So over 50 UK breast units have agreed to participate, and aim is to recruit consecutive eligible patients recently within the last 6 months diagnosed with local region recurrence with or without distant metastasis. We aim to open the study for 2 years, and our target recruitment is 500 patients. Patients will receive standard treatment as per local unit protocol, and units will document data about the initial and recurrent breast cancer on the REDCap database, and patient will be followed at the local units to determine oncological outcome. This is the study flowchart. So patients are enrolled who are diagnosed with local region recurrence and meet study inclusion criteria. They do need to undergo informed consent for study recruitment, and then patients are staged according to local unit protocols and be allocated to either isolated local region recurrence or local regional recurrence with distant metastases, and followed up to determine oncological outcome and study endpoints. The consent does include optional consent to access archival tumor tissues or slides, and this is to aid design of any future translational studies to distinguish true recurrence as opposed to new breast primary. The study has been adopted onto the NIHL portfolio. It's on the associate PI scheme and has recently been badged by the ABS. The MPQ manuscript has been submitted for publication and is currently undergoing review, and the REDCap database has been finalized, which is hosted by University of Manchester. The prospective cohort study opened in Leeds in December. We've so far recruited 15 patients, and we've started site initiation visit for other sites. We've recently just opened Wakefield and hope to open other sites in the upcoming months. I would like to thank our study steering group, and I would also like to thank our list of collaborators from our 42 UK breast units who participate in the National Practice Questionnaire. And very happy to take any questions, and this is the contact details for our study team in Leeds. Thank you.
Thank you, Beck. That was a lovely presentation. I think we're going to do questions after all the study updates. So if anyone has any questions for Mr. Kim or Ms. Potter, if we can type them into the chat, and we can have a little bit of a Q&A session after the study updates. So the next speakers are Mr. James Harvey and Mr. Rajiv Dave, who are going to update us on the iBRA-Net localization studies. And again, for those of you that don't know, Mr. Harvey is an oncoplastic breast surgeon at the Nightingale and Prevent Breast Cancer Centre at Manchester University NHS Foundation Trust and has been since 2012. He's national lead for multiple trials in Manchester and the UK and is chair of the iBRA-Net Localisation Committee. And Mr. Dave is a consultant oncoplastic breast and endocrine surgeon, also based at the Nightingale Centre. He serves in several regional and national clinical leadership roles, including on the Association of Breast Surgery Academic and Research Committee, is a steering group member of the UK-Kenya Healthcare Alliance, as well as being on the iBRA-Net Localisation Committee. So I'm going to hand over to the pair of you. Thank you very much.
Thanks, Jenna. Good morning, everybody. You get double trouble for our talk because Rajiv and I are incapable of doing anything on our own. It's really a talk about how this study has kind of come to fruition, and hopefully for anybody out there who's thinking about starting a study, maybe a little bit of a route map about how you can set up your own study and get other people involved to help you. So we're just going to run through a little bit of background of how we arrived at designing the study and the steps required in setting that up, and how we worked out the funding and the commercial partnerships involved in the study, and how we think that helps the iBRA-Net group run with their studies. Rajiv's then going to take over and talk a little bit about database design, the study support and the team involved, and how the shared learning worked in the study. So the background of all of this really, and the background of a lot of iBRA-Net's work, is the Cumberledge Review, which looked at vaginal meshes and various other devices. But I think for me, the overwhelming message of the Cumberledge Review is that over the last 20, 30 years, we've been very poor at looking at medical devices. We weren't putting the patient first. So there was a culture of a rep brings you a device, looks good, first we used it in a patient, maybe used it in a few patients, and then another unit used it in a few patients. But there was very little in the way of patient consent. So patient consent in letting them know we were about to use a new device, patient consent letting them know what is known about the device. There was a lack of audit structure for collecting short-term and long-term safety data, and there was a lack of a mechanism for feeding this data back to the manufacturer and to the patients so that they know what they're getting let into. So iBRA-Net has had great leadership for setting up device studies, and I don't think it can be underestimated what Chris Holcomb and Shelley Potter and the iBRA-Net team has managed to set up. The iBRA study essentially set up a methodology of having a group of surgeons in the UK who have a common aim. That is a huge kudos to us as probably mainly British surgeons listening in, that we have this common aim and common network of people who are willing to put the data together for, as I say, a common aim to find out information about our devices. The iBRA-Net localization study could not exist without building on the platform and the shoulders of what has gone before, in that the hard work, the foundations really are the iBRA-Net community, the willingness to collaborate, and the willingness, I think, for all of us to put the work in to submit audit data, to spend long hours collecting data and submitting data for, let's say, a common good. And I think when other people around the world look at the success of iBRA-Net, I think they are now beginning to realize that collaborative research in this way is extremely successful, and we are steps ahead on that front. And I think Rajiv is going to touch a little bit later on about some of the international studies that we're just beginning to get involved in, but they are really based on the iBRA-Net community. So as we know, the localization study really is based on no innovation without evaluation. The key to this study really is around using the iBRA-Net community, but any research question that we need to ask has to be a relevant clinical question. So I can come up with a lovely research idea, but really for it to be successful, it has to be an interesting research idea to the rest of the iBRA-Net community. So it has to be relevant and timely. I think the point at which the iBRA-Net localization study was launched, that we'd had a little bit of experience of using MagSeed, but it certainly was, when we started the study, very few units were using localization devices other than wires. So there was a clear clinical need for other units to start using these new devices and other units to therefore join some sort of audit process. We needed an experienced and motivated team. I think when we're building a team for any study, we all need to have an understanding of maybe where our own limitations are, what we can provide as an individual and what we require as a team. Certainly as a research team, you need to have all bases covered. The reason that Rajiv and I are both here is that we have, I think, in a way, symbiotic skills, is that Rajiv certainly has many skills that I don't have, and I probably have a few skills that Rajiv doesn't have. It doesn't mean that we're not capable of doing the other aspects, it's just that I don't think you can be master of all skills, and therefore building a team is what's required for any of these studies. I think the other thing that we've learned from the iBRA-Net community is that a lot of these studies have been driven by trainees. A number of trainees have been involved in the setup, also in the writing of papers, and also in the collection and submission of data. I think a lot of the iBRA-Net data has actually come from the bottom up, from trainees and registrars pushing their consultants and maybe the older generation into submitting data. And certainly the localization study with Jenna, who's chairing this session, and also Hannah, one of our foundation trainees, have done an amazing amount of work on setting up our study. So most of the localization study was set up in advance based on our iBRA-Net. All that stuff was done already. What we needed was to establish some funding for our study, build a team of expertise, design a protocol. One of the key successes for the localization study was that it's a fast-moving market. So new devices were going to come online every, 6 months? And therefore we needed a study design that was going to change fast. Traditional funding mechanisms, such as applying to NIHR, are excellent, but quite slow moving. So from concept to study starting, you're probably talking on average 2 years, whereas we needed a study that would have a setup period of months. And we also needed to set up a database that worked. So the idea of the iBRA-Net localization study really was to design a study that had a fast turnaround. So we designed it so that we would look at a control group of wires and an intervention group of MagSeed, and then we would build a platform study so that we had the control arm, the intervention arm, and then we could add other arms in as we went. And the adding other arms in should be designed that they could be added in fast. I think that this works well for lots of devices. So you could apply this to, I think, ADMs as much as you could to localization devices or negative pressure dressings, whatever it is you want to do. If you design a core structure of valid outcome measures, you can then measure them on all the new devices that come out. The other thing that we wanted to do was describe the current practice of breast localization devices, which was the first national practice questionnaire, at which point very few units were using anything other than wires. And we wanted to look at shared learning. So the study setup really was that the concept of this at the time of designing the study is that very few units had experience of the devices. The normal way of collecting data on devices would be for lots of individual units to do, let's say, 100 cases and then to publish them. This in itself is inherently, I think, biased, because you're likely to only publish positive results. You're all going to have different outcome measures, and therefore it takes a long time to accrue quality data. And even if you took 10 units data and put them all together, because the outcome measures are not the same, you can't really combine the data. So the concept really is that we are more powerful together if we have the same outcome measures and we're all measuring the same thing. We then developed a study team with some expertise in localization devices, in databases. We use Shelley Potter, Chris Holcomb's expertise in setting up collaborative studies. The study design was developed with the help of the ABS, and they have a sandpit session at the ABS. So for anybody who's thinking about developing a study, I personally think that's a really good place to start. You've been involved in those sessions as well, haven't you, Rajiv? And I think they're really positive. You can sit in front of a group of people who all have research experience and bounce the idea around. And I think it's also quite a non-threatening environment, which is a good place to start. The funding for this study, we required money for database setup, for open access fees, for generally overheads for the study. And this came through the ABS funding stream. And again, this is an open stream, open to anybody, trainees and consultants. If you've got a good idea, you can submit it to the ABS. You will have a fairly decent chance of getting funded if you've got a good idea. We then needed to develop our study resources. So this would include a protocol, patient consent forms, audit tools, databases, and so on. So the first study from there was born and then marketed, and uptake was pretty good. And then once the first magseed and wire study got going, we realized that there were going to be other arms added in. We felt that the funding stream for ABS funding it was no longer viable, and that we needed some funding for somebody to run the database on a full-time basis, to do the marketing, to answer all the emails. So several things changed for the setups for the subsequent arms, and really we involved commercial partners. So having conversations with the manufacturers about what they wanted for their device. And I'll talk a little bit more about commercial partners in a second. I think the other thing that really changed as the study grew is that trainees had a greater role. Jenna and Hannah had a greater role in supporting the study, writing manuscripts for us, and generally in having the time and the energy to drive it forward. So in the kind of 3 years since the study has been going, we as a group have published the National Practice Survey, which Santosh, who's one of our trainees, was lead author on. We've published the methodology, which Hannah, one of our trainees, is a lead author on. And we have collected and reached our primary outcome for wire and magseed localization, and that has been published in the BGS last month. So as an individual, if I was doing this study on my own, let's say, there is no way I could achieve all of this, whereas because we have a team of people writing and taking responsibility, we can publish things much faster. It also means that collaboratively, by all putting patients into the same group, into the same audit, that we collected the 950 patients in each arm tremendously quickly. And again, if we did that as a sole unit or 1 or 2 units, that would take us years. So commercial partnerships, I think commercial partners are beginning to understand the power of iBRA-Net. For a commercial partnership to work, it has to work as a partnership. Obviously, it has to work for us as researchers, and it has to work for the commercial partner. So you have to think about, do we have common aims here, and what's in it for us? When we started iBRA-Net, there was a lot of discussion about where the funding should come from. Should it be neutral funding from NIHR and grants, or should there be commercial partnerships? And I don't think there's one straight answer for this. I think there's a place for each of them. The advantage of commercial partnerships are that they are relatively fast moving. So for instance, if a commercial partner wants to fund a study, the money is pretty much there ready to go. So for an audit study like this that you want to set up in a few months and get results within a year, 18 months, I think they work really well. The MHRA and European Union want more post-marketing surveillance data on devices. The manufacturers are required to provide that data as part of their CE marking process. So the commercial partners are now motivated that they want and need to collect that data. They can also see from the iBRA-Net localization device study that the turnaround time for them getting large, reliable results is quite fast. The MagSeed study essentially is about 19 months from start to the study to publishing. What we have to be aware of is the commercial partners have their own agenda. There are certain things that they want. They want reliable results. They want value for money. They want something that they can market. So we have to help provide them with what they need whilst protecting our research interests. So the key thing for us is that the research is independent and that we control the methodology and we can publish the results as we wish. From the commercial point of view, we have to give them something back. So what are we giving the commercial partner back? We're giving them results. We're giving them reliable results. If they think their device is going to work, they want to prove it as soon as possible. The sooner they can prove their device works, the bigger their sales. So if we think the device is successful and is going to be useful for patients, we can offer commercial partners essentially what they see as money, because results and good results mean that they will sell more product. One skill set that is required, I think, for commercial partnerships is really listening to them, listening to what their needs are as a company, and trying to align ourselves with them. That's not to say that we are working for the company, because we're not. We are just setting out to the company, this is what we can offer you for a price. We think it benefits you. It benefits us as a surgical community because you fund our important research, but we also have something to offer you. So I'll now hand over to Rajiv.
Great, thanks, James. So I'll just go through a few other bits about the nitty-gritty about the setup of the study itself, and I'd just like to focus initially on the team. It's very clear that all the team that have been involved so far in the localization studies are very involved in the study. They're all motivated individuals who have an interest in innovation in surgical devices, and people have approached the iBRA-Net overall team about being involved in localization studies, people who are pioneers with particular localization devices. And as previously mentioned, it's important to ensure that we've got both consultant and trainee representation. Now, the consultants that have been involved so far in the study, both in terms of putting patients' records into it, but also within on the steering committee, it's been important to make sure that it's from a geographically diverse area within the UK. And that is to ensure that we're getting representative data from across the UK. As the platform study has developed, it's also been very important to ensure that people involved in the steering committee are experienced users of the device. So although James and I have been running the localization study portfolio overall, we've included people with different arms of the study who have the experience and have used that particular device to help design the protocol and actually have a discussion about any particularities of that device that we need to find out a bit more about when it comes to setting up the database. With regard to the trainees that have been involved in the study, from myself as starting off as a trainee on the MagSeed study, and the people that are currently on this call as well, and there've been I think at least about 6 or 7 different trainees involved, and all have been extremely motivated and have been recruited through a competitive process. And it's important as well, if you're getting trainees involved in your studies, not just within iBRA-Net, but this is a message across the board, is to give them the autonomy to actually be able to carry the study forward themselves and make some decisions and make some plans. and they should be empowered to be an inclusive part of the team and a very important part of the team. And also, one major part of the team, as we mentioned before, is the iBRA-Net and ABS membership, without whom none of these studies would be possible. James has mentioned a bit about the protocol and how we have designed this as a platform study. So there is a core protocol which can then be adapted to each device that comes on board. But I'd like just to discuss very briefly about the REDCap study design. As I think everyone on this call is familiar with REDCap, but I'd like to just go through a few things that I think are important with regards to designing a REDCap database. The first thing is that it should be pragmatic. And this is a decision that takes place right from the moment you hit go in discussing the study and the outcomes. There needs to be a balance here between the completeness of the data that you want from this study, but also you need to take into account the burden of data entry. So it has to be user-friendly. I mean, it has to be designed with the user in mind and not just the researcher. You're better off having 1,000 records, perhaps with fields that you may have wanted to include but didn't get to include, than 200 records with detail that you perhaps are not even going to be publishing later on. It needs to be robust. So you need to be able to answer the primary outcome. And that is in keeping with what I've said earlier about the database being pragmatic and user-friendly. But also you need to think about how you can be ambitious about the secondary outcome without overdoing it as well. And for example, within the localization study, the primary outcome has been removal of the lesion that we want to localize. But with secondary outcomes with regards to time taken to perform the surgery, margins, re-excision rates, etc. It's also important to be able to publish these. It's very important data that users would want to know. So again, this needs to be taken into account while you're making a REDCap database and how you can integrate this without making it too much of a burden. And the way to do that is have a database that flows well. So design your database that emulates the availability of data in the stages that it is received. So for example, you might want to start entering data at the time that the patient actually had a diagnosis and you've decided that you are going to be performing a wide local excision with a localization device. The next phase of your data collection should then include what happens after surgery. So margins, for example, decisions made following the MDT, any problems that were encountered during surgery. And then finally, the post-op pathological data and any decisions that were made from re-excisions, for example. And having this flow would hopefully reduce the number of times that your users are going to have to go onto the database to actually try and enter data. REDCap has a very intuitive structure known as branching logic. And this allows you to be able to have questions appear and disappear based on previous questions that you've answered. So if there's a very straightforward process of a patient having a wide local and center lift biopsy that was completely straightforward, good clear margins and no further action required, you want that to be able to occur very quickly without having all the other questions that come up. And effective use of a branching logic can really make the database on REDCap flow very well and easy to use. And to this effect, it's actually very important to trial the database. Both those who are regular users of that particular device and those who design the database as well, to make sure that there are no tweaks that you can make to make it flow even better. Or again, as we spoke about with regards to the flow of the database, to make sure the questions are in the right position as well. And you've also got to be able to adapt once your database is live as well. And the audit design of this study makes it easier to change the database without the need for formal amendments. But it's also important when you're doing this to inform all the users and also make sure that you're not losing any data as you're doing it. And within the first 5 to 10 records, I would suggest that if there are any major problems with regard to the database, that you would find out at this stage. As James had mentioned, the way things have changed over the last few arms of the localization study devices is that we now have a research assistant in place. It's impossible to perform this study as a set and forget. You can't just set it up and leave it and hope that in 18 months' time you're going to end up with a complete database that you can then take forward and analyze. This is the kind of study that needs regular attention. It involves people's time. So some people may forget that they haven't updated their databases. Lots of people just don't have time and like to do it all together as a bulk at the end. And sometimes there are some questions that people have, and having someone that can regularly respond to those questions and regularly look at the database and make any changes or prompt people is quite important. And having someone that can manage this database and create newsletters as well and liaise with users has been pivotal in how we've progressed with these localization studies. The other roles of the research assistant is to advertise this, is to interact with people on social media, to set up meetings, to take minutes. And the ideal skills of someone in this particular post is someone that is very good at this networking and also has strong IT skills, such as use of databases, design of flyers, etc. And this is, I think, has been shown in the progression over the last few, the last 3 arms of the localization studies. So being a platform study with an inclusive membership across the steering committee and a consistent core membership, which means that every single arm has been managed in the same way, but with very strong input from the high users. Looking at the very first arm with Magseed and Wire, compared to the Hologic arm, which we've almost due to complete coming up soon. You can see that there's been a much stronger recruitment, and I think we've learned our lessons in the first couple of arms, and we've applied this to the next few, and also we've had a research assistant as well. And coming to the analysis, it's very difficult to manage databases like this because there's so many possible fields. The way the database finally appears is very much about how you've set up your REDCap database right at the very beginning. And these are lessons that have been learned over the last 5 large REDCap databases. It's important to look at what the final database is going to look like at the time that you're designing a REDCap database. The way the records appear vary depending on the minor changes that you can make. For example, whether or not it's a multiple choice question or a single choice answer, and how easy that's going to be for you to make sense of the data at the end. And we've been lucky that we've had a very enthusiastic statistician working with us, that we've had a pre-approved analysis plan, which has had some adaptation once we've received the data and realized that things weren't exactly how we expected them to be. And it's important to have someone that understands the data on your team. So someone who's an in-depth knowledge of the database, and also someone that is a user of that database, so knows exactly where and how the data exists within that database. And we've also had to adapt ourselves to some innovative ways to actually report the data. And we were stuck in a situation where we were trying to figure out how best to look at the weight of the specimen according to the size of the cancer. And there wasn't really anything out there to help guide us. So we came up with a metric, which is the size of a millimeter squared, and that was something that we had to discuss on along the committee, and I think in the executive committee as well. And this need regular meetings with the rest of the steering committee. And I think the Zoom effect over the last few months, last couple of years during the pandemic, has actually helped with regards to this, because we've met regularly, we've had discussions about the database and the study progression, and we've made some changes accordingly if necessary. Coming to shared learning, this is a very important part of the study, the platform study that we have. It gives people ownership of the data, and it involves all members of the surgical community to be able to talk about things in a free and safe manner, and in one that's quite supportive. But however, I still think this remains difficult. People are very good at reporting problems if they were to occur, but we're still finding it difficult when it comes to learning points and best practice. And often this needs to be prompted. The problems are very well embedded into the data collection, but I don't think the learning points and best practice are, and it's quite difficult to do this within data that's quantitative. And hence we've tried to have shared learning events. For example, the MagSeed one, which we had at the UK IBCS a few years ago. And we've got a Hologic shared learning event coming up on the 27th of April in the evening. And this gives an opportunity for people to be able to present cases, to have a discussion about best practice, and as a community move forward, and actually how we can use these devices to their best capability. So where do we go from here? We currently have international collaborators on the Hologic and SavvySCAR arms of our studies, and we have now just developed a European partnership with the team who are running a MELODY study, which is a multiple device platform study that Yazan is going to be leading on from the UK perspective. We also have the Pintuition arm coming on board, and I can see Ed on this call, who's been leading on that. And we're hoping to try and set up a qualitative study, which might be included within the MELODY study, or might be one that's separate as an iBRA-Net study. And we're still, it's still unclear whether a trial is necessary here. We're getting robust data here on the usage of these devices. And once we have all of that together, that may be a discussion that we need to have. So thank you very much. I hope we haven't overshot our time, and James and I will be happy to accept questions.
Thank you both for that really informative talk. And I think it very definitely, all of the talks this morning, in fact, have highlighted the importance of collaborative working. I haven't had any questions so far on the chat, but obviously if anyone does have any questions for any of the speakers so far this morning, if you can type them into the chat. And I think it's important just to emphasize, obviously, if there are people listening today who are interested in getting involved in any of these studies, you've seen that all of the studies have individual emails. There is information on both the iBRA-Net web pages and the Mammary Fold academic collaborative web pages for those trainees in the audience. And just for keeping up to date with studies and opportunities from iBRA-Net, you can also join the mailing list, and I think Yazan has just popped that in the chat as well for everybody's information. So if there are no questions at the moment, I think we'll move on to our next speaker, and we can always raise questions again just before the break if anyone does have anything they want to ask. So our next speaker is Mr. Tahir Masoodi, who is going to talk to us about how to successfully set up and run national studies in a district general hospital. Mr. Tahir is a consultant oncoplastic breast surgeon at the Rotherham NHS Foundation Trust and has been for the past 4 years. He has a keen interest in research and education, and in addition to being a member of the iBRA-Net Localisation Steering Group, he has also recently hosted the inaugural South Yorkshire Breast Surgery Meeting. So, Mr. Masoodi, I'm going to hand over to you. Thank you.
Good morning, everybody. I'm just trying to set this up. can't seem to get this up. Can you see it now?
Yes, it's coming.
Okay. Right. I'll just go back. So, good morning, everybody. I would like to really thank Shelley for allowing me to share my experiences with all of you guys about working in a DGH and also trying to set up studies and trials in an environment which is not particularly suitable due to the service demands and other factors that go on in a district hospital. The genesis of this talk basically came from our discussion last time in our iBRA-Net meeting, where we were talking about all these trials and studies and designs and everything. But then we thought, how does it actually work on ground, where majority of our work takes place? Most of the patients are treated in DGHs, in infirmaries, and we want more involvement of people working in those centers with the studies. It could create a really big database if we were to get most of these units involved and interested in data gathering. So that is where this talk comes from. I'll just share my experiences from the time when I started at Rotherham and District General Hospital. I just put this map up to show where it is. It is quite near to Sheffield, just off the motorway. And we've got two other hospitals, Barnsley and Doncaster nearby. So most of the patients come from this triangle here. And being near to Sheffield is also important in the sense that most of the times we are expected to be kind of working in the shadow of the big hospital there. So that also poses some difficulties when we try to initiate things on our own. So that is why I put this map up first. So basically, this is an idea of what our unit is like. We cater to a population of around 120,000, and we provide 72 new patient referrals on a weekly basis, and about 250 to 300 new breast cancer diagnoses are seen through our unit on an annual basis. And proudly, I can say most of the cancers manage to get treated within the target time. And we have been offering all reconstructions except, of course, DIAPs from our site. And we continue to do it all through the pandemic as well. Just a gap of 2 months where we didn't do any reconstructions, but we carried on working throughout at a private site nearby, which we made a green site. This is our unit. We've got 3 substantive consultants, 1 associate specialist. There is 1 senior clinical fellow who I managed to rope in because we don't have trainees, senior trainees in our setup there. And obviously always running short of SHOs, and also I managed to get a senior clinical fellow who helps us in research and this kind of stuff. We've got 4 breast care nurse specialists, and we've got 1 secondary care nurse, which is again a new thing in the area. That nurse basically caters to patients who have got metastatic breast cancer, and then they get very specialized care from her, and she is dedicated to that cohort of patients, which is really good. And then we have got on-site screening and radiology services. Pathology and nuclear medicine is at Rotherham. The only thing that we get remotely is oncology, which is provided by Sheffield Teaching Hospitals, and they basically see our patients. When I started in 2018, obviously we all know the predominant method of localization was wire, as in other units in Rotherham as well. But before I started in Rotherham, I was working in Lincoln, and I had participated in a pilot study where I used MagSeed, and I was really impressed with MFAC guided localization, and therefore it just stuck to my mind. And when I started in Rotherham, I started talking about it, and I felt this is the best way forward based on what I had experienced. So I put this proposal in our local CSU and the managers, and straight away, people laughed, and I was greeted with skepticism, and it felt very daunting. So I got a bit down and thought about it, and then I met with the EndoMag reps, and they helped me plan another pilot at Rotherham Trust. So that basically was an uplift, and I said, right, there is some light at the end of this tunnel. So again, I proposed this pilot, and people in the hospital, in the governance, they raised their eyebrows and said, we have never used this and all that. So I put it through all the governance committees, local governance, divisional governance, and trust level governance. Then finally, I got the approval, and we had to register it as a quality improvement study in comparison to the wire localization, which was being done there. Then the next step was to get my colleagues on board who had always been using wires. And thankfully, they're all very cooperative, and they said, fine, we'll go ahead with it. Then the next more difficult step was to get the radiologists to agree, because radiologists are so pivotal in our work. And some of the experienced radiologists in our unit were really not happy to change from, age-old techniques and conventional methods. It was quite difficult to get them on board, but finally they agreed, and we started the study. And when we finished this 25 patient pilot, I presented this in our local audit and governance meetings, again, the results, and obviously they understood that it is at par with other method. Then they asked me to write a business case, which I did duly, but again, it was not approved by the higher management, and they started putting up price and other things, such obstacles. So at that point, COVID-19 came along, and we had to really think how to operate. And we identified a green site, which was like which is a private hospital in the vicinity of Rotherham main hospital. So we decided to shift all our work to that hospital. And then the question of localization arose, and I promptly said, let's get the MFAC. And that actually was the turning point. And I don't know, somehow they managed to get the funds, and we got the MFAC put up in our hospital at that site. So at that time, I also enrolled with the MFAC trial, got in touch with James, and we were doing the iBRA-Net networking, and we enrolled on it. With the result, now what we are doing is currently we are using 95% of the cases are having localization with MFAC. And subsequently, we made a move towards MagTrace. And again, this time I spoke to the CSU and our local governance committees, and they provided the same kind of obstacles. And I said, let's start a pilot on 30 patients. And we replicated the process that we had started in the first place. And we have finished that, and we have accumulated data, and we are hoping to get the approval for this in very near future. What I learned from my experience from these two studies, how I set them up, was basically to take the whole team into confidence based on what evidence is available outside our trust, nationally as well as internationally. And when there is an idea, you just have to float it. So I spoke to the consultants who are part of the CSU, and obviously our own colleagues, the breast team. First of all, I had to get the support from them. And when they brought on to the idea, then because they sit on various committees and they have a say, and they can support you when it is being discussed at various levels in the trust. So that that proved important, because I had talked about this so many times in all the meetings to all the consultants. They had this in their mind, and whenever it came up for discussion, they said, yeah, fine, we understand this process and let's support it. And obviously I set up the pilot, which again helps as a study or as an audit. And governance processes of the trust, they need to be overcome. And I went personally to all the meetings, explained the importance, the necessity, and tried to reason with people, because a lot of questions are not clinical, but people, if they raise those questions and they don't get the answers, they will stop the process and it will fall for months. So it's better to be there personally to be able to answer and give some responses. And the data, collection of data has to be really to the best possible ability, because figures speak for themselves. And if the data is correct and right, you can prove your point. And as Jenna earlier said, I presented this in our regional meetings, the data, and I encourage other units to participate in it, and that again helps. So moving on to this, from there, I have spoken to our trust about ethnic trial, which we have started in our unit. But that was only possible if we had the MAG-seed, the MAG trace available, because that is used for localizing the lymph nodes, mapping the lymph nodes in the axilla. So we had to lay down the groundwork before we could go on to ethnic trial. So all these things work with each other, and then we are able to say to the trust, the research department, that we can set this trial up in our unit. So basically, the steps were the same. We went on understanding the trial and checking its feasibility locally. I expressed my interest in participating in this trial. Then again, preparing the ground, getting the colleagues on board, and the larger breast team as well, because it involves oncologists as well as the radiologists to be able to do their bits. And then the research department, which was almost defunct due to COVID for the last 2 years. So we had to get a nurse recruited, tap into the local resources and see how we could get somebody on board and try to get their interest into this trial. So that's again a difficult process, but not impossible if we have the will to do it. And then I expanded the delegation log, which is basically you get more people on board, more people interested in the trial, so that the participation is increased. All the Q&A requirements need to be met. So again, because we have got oncology services from Sheffield, it wasn't easy to convince the Q&A, the team from Sheffield, to get involved into this trial, because Sheffield themselves are not yet recruiting for the trial. So it was a marathon task to get them to agree to this. But again, I had a number of meetings, cross-site meetings, and I had to go to Sheffield to see the people there, try to remove their apprehensions and reservations, and finally to get them to agree and to participate in this trial. So it's a lot of work, but if we have the will, it's not impossible. I know this talk basically is to get people to understand that it is something we can all participate in at a district level, smaller hospitals where there isn't much funding available. There are no trainees, there are no juniors to help with data gathering and groundwork. But if we have the will and we stay steadfast, we should be able to get it done and participate in bigger trials, help in data gathering, and make a name. So that was what I wanted to share with other people, so that they can feel encouraged and perhaps want to participate in national trials. Thank you.
Thank you, Mr. Masoodi, for that very insightful talk. We do have a question for you from one of our audience members. They're asking, how did you ensure that your colleagues were adequately trained to undertake the technique safely?
Yes, what happened was, since I had personally done my training in another hospital, so I was quite experienced in this, and we got the reps from EndoMag to come and supervise us during the procedure. So I would, in addition to myself, would have a rep from the EndoMag and my colleague who would participate and who would undertake the procedures. So there was a double check there.
That's brilliant, thank you. So can I ask if anyone else has any questions for either Mr. Masoodi or any of the other speakers that we've had this morning? Yeah, Tim, would you like to ask yours live?
Yeah, thanks. Question for James and Rajiv about the MagSeed audit. Could you explain again for the audience the data governance and any data protection issues you faced? And was this was set up an audit, wasn't it? And the second question is, if you were now, there's a few international MagSeed audits or studies going on. If we were to try and pool this data for a sort of meta-analysis or comparison, what data protection issues are you anticipating, or data governance issues?
Shall I start, Tim, with the response, and then maybe Rajiv can chip in with bits that I miss. The data is a difficult one. We've essentially worked on the initial principles of iBRA that the data really belongs to all of us as a community. So there are several different elements of the data set that if you put data into the database from, let's say, your unit, that data is yours and will always be yours, and nobody can take that off you. And thank you very much for offering that. We have recently built a data sharing agreement just to kind of clarify who owns the data at the end. And essentially, we came to the outcome that if you submit the data and agree to take part in the study, that you agree that the data becomes part of a larger pool that then belongs to iBRA-Net as a whole. This is not belonging to the committee, it belongs to iBRA-Net as a whole. So we will publish the data on your behalf, and equally, just as iBRA held the data for the iBRA study, that other collaborators can come back to that data in the future and mine and use that data for what they wish. So the data from all our studies so far is owned by us as iBRA-Net, and we would be welcome, to share that data, for instance, for meta-analysis for other studies. Rajiv, do you want to chip in?
I don't think there's any more to say with regards to how that's set up. The other thing to just mention is with regards to GDPR, for example, Tim, I know that wasn't in your question, but in keeping with how things are done in other studies, when you sign up, we have a GDPR statement there as well on the study. But nothing else further than what James has said.
Yeah. I think the other point to be clear on is for the commercial partners about what data is theirs and what belongs to iBRA-Net. So we've been very clear that the data belongs to iBRA-Net, and as part of the commercial agreement, we have agreed to give them some data outcomes. We don't give them the database, so they don't have all the individual sort of patient level data, but we agree on what summary data points they require for instance, their MHRA applications and for their marketing tools. So we try and agree that in advance, Tim, if we can, so that the commercial partner is very clear on what they're going to get out of the study from us, so that there are no surprises, and we tend to contract that in at the beginning so that they know at this time point they're going to get a summary of the data.
Thank you both. Are there any more questions? I haven't got any in my chat. But otherwise, Shelley, I believe we're due to break for coffee in about 4 minutes anyway, and returning at about 1:45 for our keynote speakers. Is there anything you want to add?
No, just to say thank you to all the speakers in the first session. Hopefully everyone enjoyed that, and you get an extra couple of minutes for a comfort break and a cup of tea.
Yeah. Thank you very much, everyone. That was fantastic.
See our innovation. It's now time for our innovation section and also our keynote speakers. And I am absolutely delighted to introduce Jenny Lane. Jenny is an orthopaedic surgeon based in Oxford. She did her undergraduate in Oxford and then her basic surgical training in London. Her PhD looked at using big data in hand conditions. And I'm hoping that Jenny will be able to show us that it's not all about trials, that we can use big data and other methods to address and answer some really important research questions. So thank you, Jenny, very much.
Right, first of all, I hope you're seeing my main screen rather than slideshow view.
Yes,
can I just double check? Good,
yeah,
good,
perfect.
okay. Well, yeah, I'm delighted to be here. I'm sorry I'm not meeting you in person, but then equally, considering the title of my talk and being the lone orthopedic surgeon in a room of breast surgeons, maybe it's better that I'm far away with such a controversial topic. But what I'm hoping to do is to really make you think a little bit, hopefully inspire you to think about, especially thinking about what you've been discussing before the break. And now we've had a coffee and we're mid-morning, almost lunchtime-ish, and we can properly get our nerd on about big data, and you can see what we've been doing and see what you think. So I think the main thing for me that inspired me is that wherever we go now, data is part of our lives. Whether we're going to the supermarket, whether we're looking on the internet, we're constantly being followed. And whilst that's also pretty terrifying just how much Jeff Bezos knows about me, it's also a really interesting way for us to think about healthcare, what we do in surgery, and the data that is just generated as a byproduct of the medicalization and modernization of our world that we are able to collect. This is the most controversial slide I've got for you guys, and it's mainly about why I am inspired by observational data. And this for me is my little soapbox pitch. As someone who is inspired by epidemiology, for me, the reason I love observational research, or particularly research using real world data, is because I feel that it more accurately represents the life that I see in my clinical practice. So for me, the woman doing some impressive yoga on the left-hand side is how sometimes I think there's the criticism of an RCT. So in a clinical trial, you have the people who are literate, the people who consent and have capacity to do so, and people who turn up to their follow-ups. And then the woman on the other side is the woman that I feel mostly predominates my fracture clinics. And I feel that I want my research to be able to more accurately represent what I feel I see in my routine practice. There are other things, of course, that observational data has that some clinical research doesn't have as well. And that's also leads you to be able to answer a different type of question. So real world data as a phrase can produce some autoantibodies from some people. And to me, real world data defines, I define it as, it's a byproduct of the medicalized digital world. So it can also be called routinely collected data, and it can come in various forms, depending on the type of healthcare system or the type of data that it represents. So this can be generated by a healthcare setting, particularly primary care, such as we have in the UK with CPRD, or secondary care, such as the hospital episode statistics data sets that we have. Similarly, this can also be about a process of data capture. So outside of the UK, thinking of insurance and claims data, or it can actually be from a whole healthcare system. And certainly for us in orthopedics, there's also representative of some national initiatives that were initially called registries in terms of looking at a particular device or surgical type. I think with all research, there are strengths and weaknesses to using routinely collected data. I think the main benefit is that it can be used to identify real world practice and may contain some patients who are outside of inclusion criteria in trials, such as those who are at extremes of ages or are multi-morbid. But you can also have longer follow-up, which just isn't financially possible with some other types of studies, and can also look at complications that take many, many years to come through. But you also have to remember that the data wasn't generated with research in mind, and it's very important to consider the assumptions that are being made. If it's based on coding systems, do you really know what those codes truly represent? Are you getting only a certain type of patients included in your study? And also, are you thinking that you are identifying a population that you're really not, because actually you've got confounding by indication that the groups that you're comparing are actually not comparable groups. Similarly, there are some things where you just don't have enough detail, and certainly that's something I found in hand surgery, or you're only able to look at outcome in a certain way by revision surgery or complications that are recorded, and other things that are just or even more important for outcome you're just not collecting. So how can we maximize the strengths and minimize the weaknesses of using this data? So if I give you an example from some of my work, looking at carpal tunnel syndrome and carpal tunnel decompression. This was a plot that was very exciting when I first made it, that was generated from hospital episode statistics data. So this is anyone who's recorded as having a day case procedure. That could be a scan or an injection, or it could be that they've had a long inpatient admission within the UK. And I was able to look at 19 years of data to just look at the incidence of surgery in men and women. And that's what this plot shows you. And what I found most interesting and striking about this is, as you can see from the plot in red compared to blue, red being women, is that there's this huge peak in incidence around the perimenopausal age. In addition to then at the age of 65, you see an increase in both genders. And so why is that? When you're using an observational data set like this, you can't really work out what it is specifically that is driving those reasons. Is there something different between the genders that causes that difference in surgeries to happen? Is it a difference in presentation to medical services? And what is it about the age of 65? Is this something that is very socially laden with people who now decide that they want to invest in their hands? They're no longer working if they've gone to retirement age, as is traditionally happening at 65, and then moving forward. I just thought, well, okay, how can I take this further? And the first thing I thought was, right, okay, well, is this an English thing? Is this something to do with the NHS and a byproduct of the way that we have healthcare in this country? So I met Igor Immerman, who is an associate professor at UCSF in sunny California. And he said, well, actually, we've been using a system called Pearl Diver. This is an aggregated online platform that you can purchase. And you don't get to see the data underneath it, but you're able to see and look at trends in incidents. You're also able to run some automated analyses. So we said, okay, carpal tunnel decompression is one code, is very commonly done. Let's see what we can see. And actually what I found was that it was nearly impossible to compare the two data sets because the data was so different. I could look at overall trends, but I couldn't look at anything further because it was just so heterogeneous. And interestingly, you can see here, and this really shows you one of the things that you have to be so mindful about when you're looking at big data. The plot on the left was excluding Medicare, the free data that kicks in at 65. And you can see that there was a difference between the genders, but there wasn't that striking difference that we saw in UK data. And then if you add in free healthcare that kicks in at 65, you can immediately see the difference in the incidence of surgery, which says something interesting in itself about healthcare in the US. So I think the traditional approach of using big data is a bit like this analogy. So I have a tool where I can use it in English data, but it can't easily be replicated elsewhere. It's slow, it's messy, and it isn't scalable. So what about if I was able to use something like a travel adapter to be able to replicate a study in other forms of real-world data from other countries and other healthcare systems? Well, this is something that I've been doing for now and is something that is driving my research forward. So the observational health data sciences and informatics community is a varied network of individuals from around the world, and it includes people who are based in industry, in academia, some governments and some healthcare organisations. And now, especially after COVID, where there's been a lot of investment in this type of research, covers a huge proportion of patients. And it's based upon a common data model. And what this does is it translates all different areas of healthcare data into standardized areas, aligning different coding systems and different data structures. So one way of showing it in an infographic is like this. So you have your own data that sits behind your firewall and never leaves, because also you don't want to share it more than anything, but the most important part is that there's privacy by design baked into this, because as we all know, the constraints around keeping data secure and safe is just absolutely paramount. So your data stays in your home institution, and then it's translated into a common data model. And what this enables you to do is enables you to communicate to other healthcare systems and other data products. And so in that sense, that's where this analogy of a travel adapter comes in, because you have to be able to communicate with other departments and other groups, but you can do that by the fact that it's your data has been translated into the common data model. The whole community is based upon open source and data being freely available and really being about open science. What this has led to is the generation of open science and open source platforms to design and execute analyses. And this enables things to be reproducible, and also for all code to be fully specified. And part of this has been a really great journey for me closer into informatics from orthopedics, and looking into the use of full code repositories. And so with any of the research that I've published here, you're freely able to reproduce a study if you want, because all of the R code is there. And also by generating things like interactive Shiny applications where you can really interrogate the data as well, which is important when you're opening your research to the science community, to enable people to really interrogate what you've done. The good news for us, certainly at the moment anyway, is that we remain part of Europe for further focus on developing this community within Europe. This is called EDEN and is funded by the Horizon 2020 project. There have been several data calls now for partners, and it's increasing across Europe, and that means that there are increasingly more collaborators that you can work with, because the data has been transformed and mapped to the common data model. Here's a working example that's a little bit closer to home for everyone. So part of my PhD, I was really interested, having seen that initial difference in the genders for the incidence of carpal tunnel decompression surgery, is I wanted to think about the role of female hormones. So for one element of this, I actually looked at the role of aromatase inhibitors, and that was in part led by systematic review in the area, and also the biological plausibility that is discussed in orthopedics for the role of estrogens in developing musculoskeletal symptoms. Now, of course, as you're all very aware, there's huge evidence supporting the role of aromatase inhibitors in the treatment of postmenopausal breast cancer. And therefore, what I wanted to know is whether, if we could look at this in the Odyssey community, whether we saw a difference in the incidence of carpal tunnel surgery, in addition to other surgeries for osteoarthritis and for tendinopathies, between women that use aromatase inhibitors and women that used tamoxifen. Initially, I designed the study in CPRD using UK data, and what I was able to then do was to call for collaborators, share the analytical packages that I generated, and this was then replicated in 17 data partners in 9 countries. This, of course, led to there being over almost nearly 1 million women in the study across the world. So not just in North America, Europe, but also in Asia. One of the things I wanted to introduce you to are some ways of thinking about the validity of the data and also the validity of the study design and the analytical packages that you use. One of the ways that this is done is by something called cohort diagnostics. This is where you start to really think about the population that you include. And here, this package, which if you want to look at it, if you look at the QR code, you'll be able to look at it online, is this shows you the populations that would be included in your study if you continue to use the analytical package that you've generated. It also enables you to look at seeing whether your data partners have sufficient patients within their data sets in order to contribute. You're also able to use these packages to look at incidence rates and to really sense check whether you think the patients that you're including really are the ones that you want to use. So for example, in this study, one of the ways we defined a postmenopausal element to the cohort was that they were over 55. And what I wanted to do is by looking at here, you can see there are 3 data sets, CPRD, Medicare in the US, and then CIDIAP, which is a data set from Spain, and looking really to see, well, was I including anyone, for example, who was identified as male in their notes, and anyone who was under 55. You can also look at things like how long have people been in a data set, because one of the potential risks are that people come in on the day that they have an event or a surgery, and you don't have any past medical history for them. So again, whilst they appear healthy, they may have had things that are not looked at in their notes. And so one of the ways that you can really interrogate that is by using other elements of the package to look at the time that the patient has been in the data set, and also to look at the codes that you've included. It's got a element to it which is a little bit like Google, where it says, did you mean, and it shows you the orphan codes that you haven't included, which is pretty gutting if you spent a long time thinking about how you've defined your cohort to realize that you've missed out a really important code in your data set. But what this enables you to do is, prior to running the analysis, when everything is locked in, you first of all ensured that you really are running what you think you are. This moves forward in terms of actually looking at the analysis that you run. Prior to unblinding and knowing the results, you look at the quality of the data. What these plots are doing is they're looking at propensity score analyses, looking at how I was trying to balance the 2 populations of women. And the way I was doing that was by a data-driven approach, looking at over 10,000 other metrics within their data in order to try and produce the patient groups that would be as balanced as they possibly could be. And these plots show you how balanced the groups are. And before actually saying whether a data is of sufficient quality to be included in a result, we define what we think the adjustment should be. So for example, here, the plot on the very left shows that the results should have a difference between their propensity scores of less than 0.1 for a data set to be included, which unfortunately means that some people run your study and then their data doesn't have sufficient quality. But one of the things that is really important about the community is that you're very open about all of these processes before you begin, and people who run the data, people who contribute are all co-authors and enable you to generate the final result, but their data may not actually be included. Finally, here's a little spoiler for you, which I'm sure you're not surprised to see, but hopefully later on in the year, you'll be seeing more of these results. But the main aim of all of these studies is that once the results are available, they're also put up online along with obviously the publication that you generate. And this enables people around the world to come back to you and really ask you and really robustly investigate your study to see whether you have generated the results that you think you have, and if there are any big flaws in it, which, you know, for science and for progress is really important, if not a little terrifying. As you can imagine, COVID was a huge moment for Odyssey, and something that I ended up, even as an orthopedic surgeon, spending a lot of time looking into. If you want to read more about it, the 3 QR codes at the bottom are for 3 of the larger publications that we did during COVID. We started off with a study-a-thon, which actually now, I can't believe it's quite 2 years ago, where I spent a long time in this room that I'm sat in right now, talking to people across the world. And the main thing we looked at the time initially was about hydroxychloroquine. And in a time where we were all going back repurposed in the NHS and doing very different roles, for me, the noise of the lack of knowledge around COVID and the way things were spreading globally was a reason to use these skill sets, use these tools that we had to try and cause progress. And this was a way that we were able to have an influence on public health policy around the use of hydroxychloroquine, both in the US and in Europe, which was really exciting to see that change in policy based upon some work that you've done. And then finally, what I was also able to do was to take forward this idea of a study-a-thon, and I tried it out in hand surgeons. So last year in September, I ran a study-a-thon within the British Hand Society, and also with these partners around the world, both in industry and in academic institutions. And what we did in one day is we had 3 different studies running. So anyone who does any work with plastic surgeons may know these 2. This is Ricky Wade and Justin Wormold, who are great colleagues of mine, who ran a group running a systematic review, trying to identify the evidence base for the characteristics of adults who have proximal row carpectomy, arthroplasty, or wrist fusion for degenerative wrist arthritis of all forms. Simultaneously, we worked with a group from Erasmus in Rotterdam, and they looked at patient-reported outcomes for patients who had proximal row carpectomy. And then at the same time, I ran a group with, unfortunately, obviously it was last September, everyone was still remote, and I had a hybrid meeting, which was an interesting moment in itself, but we were actually looking at using Odyssey in real time over the course of a day with UK surgeons in the room in Oxford, but surgeons across the world online to really define the population and to look at the characteristics of people who have surgery for wrist arthritis and then any serious adverse events that they developed from it. If you're interested, you can see a little bit online here, and you can also look at the GitHub where we put our protocol, which was fully registered, and also the code that we used. So I think overall, I think COVID has been an incredibly difficult time and remains challenging. And the things that happened in COVID have been, you know, a cause for us all to reset our lives and how healthcare and our, you know, our home lives work as well. But I hope that what I have learned and will take forward is that gives us an opportunity to really think about how we do things in research, how surgery and research interact. And is there a more dynamic and agile way that we can do our research in future to bring about meaningful change for both our own practice and for our patients? So I hope that has been interested and you are sufficiently caffeine fueled through it. And let me know if you'd like to ask any questions. Thanks.
Brilliant. Thank you so much, Jenny. That was absolutely brilliant. And it's lovely to see. It's just thinking in a completely different way. And there's so much of that is completely relevant to what we do in breast surgery, because a lot of our stuff can't be answered with trials. Does anyone have any questions for Jenny? Can I ask you a question? How hard is it to get your head around all of this?
So I don't think it's as hard as it seems. Obviously, it seems super nerdy to begin with, but actually it relies on epidemiological principles, and the large data element of it in some ways actually becomes facilitated by the fact that you work with data scientists and the community are looking for questions. There's certainly, you know, there are more clinicians in it, but there's certainly not very many surgeons. So when you come with a surgical question, people are like, oh, that's really interesting. I've written this package and I want to see how it works. And one of the things I didn't touch on here, obviously one of the things that came out of the study I looked at about arthralgia, joint pain with aromatase inhibitors was, of course, the competing risk of death. Because you're not going to go and have a hip replacement if you're not alive. And initially, the community in their packages hadn't got a Cox regression model that was where you could do a competing risks analysis. And what I think is really refreshing about them is I went to them and I said, look, we're going to have trouble with this question if we can't do that. And they went, that's interesting. And some data scientists and informaticians from UCLA then just wrote a package, and they're like, right, well, can you try it out? And I think what's really exciting about that is you're working with people who have a completely different background from you, completely different skill set, but it means that you complement each other really well because you bring something that they don't have and vice versa. They bring stuff that you don't have. So I think it's changed my mindset about being able to do everything. You can't do everything. But you just need to know the person who does know the thing that you don't. And so you can then bring what you're really strong in, but someone else is bringing what they're really strong in. So not that you don't know what's going on underneath it, but because you do need to know some basic epidemiology to run it together, but you need to be able to work and collaborate with people in order to try and get the best answers and the best studies that you can.
Brilliant. Thank you very much. Has anyone else got any questions for Jenny? I think you've stunned everyone.
I'm not surprised. Anyway, hopefully it's interesting, giving you something to think about. And I've stopped sharing now anyway, which is good. But you'll be able to find me on Twitter or email me. So people just ping me if they're interested.
Brilliant. Well, thank you so much. That was a fantastic talk and definitely food for thought. That was brilliant. Thank you. And our next speaker is going to be Ed St. John. Ed is a consultant oncoplastic breast surgeon in Portsmouth. More importantly, perhaps, he is chair of the iBRA-Net Innovation Group, and he is going to give us an update on the Innovation Group and where we are now and hopefully where we're going. Over to you, Ed.
Thank you very much. Let me just share my screen. So hopefully you can see my slides. Is that right?
Yep, Ed, fabulous. Thank you.
Wonderful. All right. Well, thank you, everyone, for attending. I'm going to give just a relatively short update on the Innovation Group. So I'm, as Shelley said, chair of the Innovation Group for iBRA-Net. I'm a consultant surgeon at Portsmouth. I am a clinical entrepreneur fellow for NHS England and founded a digital health company called Concentric. So the Innovation Group, what is it and what do we do? Well, it really fulfills three main roles, I think. One is to act as a link between industry, the people making the new products, the new innovations, and the surgeons who need to use them. And I think in the past, we haven't really had a group or a forum that interacted between the two. And that's definitely one of the roles that in the Innovation Group we try to perform on. The second is to try and identify promising and novel innovations that may need either first in man studies done or maybe first in the UK studies done, so that they can be performed safely amongst a common group, the iBRA-Net group. And then if it's successful, it can be feeded onto the iBRA-Net project stage, which is more the national evaluation. So that's the second thing we do. And the third thing we do, I think, is we give support for clinical entrepreneurs who might have their own ideas, and we let people know about what the innovation funding is available for them and how IP works and really how to go about doing some of that. So I just wanted to update you with a few sort of key topics. So firstly is just to point you again to the website and just remind you how you can explore that, talk about our industry database so far, give some case examples of some early stage evaluations, mention briefly how we can support clinician entrepreneurs, and then finally try to encourage you all to get involved as much as possible. So Yazan, our communications lead, who hopefully you'll all be familiar with, has kindly set up the iBRA-Net website. And if you haven't been to it, I'd strongly encourage you to go to it. I'm aware that you've probably got a friendly audience that maybe have already been to it, but have a play around with it. As well as on the projects, you've also got the innovation side. And if you click on the innovation, it does give you quite a lot of useful information about where we think innovations sit within breast surgery and what's currently available. But it's also a dynamic website. It's work in progress, and we'd love to continue adding any innovations that you find. Do feel free to email me directly. Do feel free to let industry let you know. And if you have a rep come to you and say, I've got this new bit of equipment and I'd love you to have a go, here's a few free samples, could you say to them, are you on the iBRA-Net website? And if they're not, strongly encourage them to get in touch with us. It's free for them to be on the website, but it's a place that means we can keep track of what's happening in this space. So for the innovation side, we've divided it into these 5 different subheadings. So breast conservation, breast reconstruction, axilla, digital health, and allied surgical technologies. And on the site, it looks a lot more pretty, but it's basically broken down into these different companies that have all submitted their innovations to us. And you can see that we've got some companies, there's definitely room for a lot more. But if you can find out about what's happening in localization, so we've got the iLogic localizer, the MagSeed, the Scout, Intuition, we've got lumpectomy system, we've got some specimen X-ray or imaging systems like the ClearSight surgical MRI or intraoperative margin assessment techniques. On the reconstructive side, we've got implants, we've got ADMs, we've got meshes. Axilla, we've got ways of exploring the axilla. Digital health, we've got a few, and I think we need to grow this. And then we've also got all the allied surgical technologies, and I've been speaking to Ethicon, they're hoping to add on their Stratifix and their other novel sutures onto this page as well. So I hope you find it a useful place to come and browse. And as I said, I hope it also is a place that we collectively encourage growth in it. And I hope it becomes, therefore, the world's most up-to-date place to come and find out what is happening in the world of breast surgery and innovation. So in terms of iBRA-Net, so the iBRA-Net projects, I think, sit in the sort of stage 2B, stage 3. This is a framework for how we should look at medical devices, and it's been taken a bit from the framework about how you should look at pharmacological drugs. But the iBRA-Net project looks really stage 2B, stage 3, and into the longest term studies. And in the innovation group, I think our remit is to focus more on the idea stage, the development stage, the early stage. So here are some case examples. So Serous Pintuition is a localization device. It is quite similar to the MagSeed in that it looks for a magnet. But what's different compared to the MagSeed is MagSeed uses a paramagnetic chip that it temporarily magnetizes, whereas Serous uses an actual magnet as the chip. And the difference there is that the collimators and the sensitivity of their device can be refined a bit. Anyway, they're a Dutch company, and we've been working with them for the last couple of years to talk to them about how they get it into the UK, initially from their pre-CE mark, and then we started doing a first in the UK feasibility. And we did that at the Royal Marsden and at Liverpool, and we did their first 41 seeds in the UK, and we saw that really, in terms of feasibility, it was feasible. All the 41 seeds were detectable transcutaneously before you started the surgery, and all 41 out of 41 seeds were retrieved. The margin rate was about what you would expect for any breast conserving surgery. And so from our point of view, this showed that this device is fundamentally feasible, safe. And so therefore, we are now going on to roll out to the national iBRA-Net localizer study, which is due to start next month. So this, you can just see on this video, how they, in consultation with us and some of the other surgeon members, they've been refining their platform, and they've now added the ability to sense in 3D navigation. So you get millimeter accuracy, and you get guidance about whether you're drifting left, right, up and down, and it gives you a sort of target point as you hone right over it. We think this will make it a very useful device. But according to the iBRA-Net localization methodology, it's now going to go through that phase. So if you'd like to get involved in that, please get in touch with me. Another example, Motiva. So Motiva, a big implant company, but they've been focusing on a few of their innovations of in regards to implants. And one of the things they've recently launched is their Flora Expander. So the different thing about this is it is an integral port expander, but it doesn't have any metal in it, which means it's magnet free, which means you can use it in an MRI. And in theory, it should therefore be better with radiotherapy, and you don't get the same scatter. So because of our links, and because we've started setting up a reputation of looking at new innovations, they've now been in contact with us, and we're working with them to try and see how can we do this both on the smaller scale and then on a national project point of view. This is another example, Exaflex. So Exaflex is a mesh. It actually has gone through a few iterations. The first iteration had problems and it had to go back and be redesigned, and it has now been redesigned. And we're just waiting on CE marking for the suture to be added to the latest design. And if that goes ahead, then again, we will do the first in man bit, the phase 1 bit, and then transition it, if safe, through to the iBRA-Net phase 2 national study. And so you can see how the iBRA-Net innovation group dovetails very nicely into the iBRA-Net projects. This is another example. So Plexa has been developed by a plastic surgeon who's currently working at Royal Marsden, and he has developed something called Plex, and this works on the basis that it heats a pad to a constant temperature and monitors the temperature it's delivering in real time via an app. And the idea is that he's done work during his PhD that heating to a certain temperature causes heat shock proteins to be made, and that actually increases blood perfusion, and therefore it increases the ability of the skin to heal. So it may be very useful on things like skin and nipple sparing mastectomies, places where we're often worried about the viability of the skin flaps, or for DIEPs, etc., where we have some concern about what will the perfusion be once we take out all the breast tissue. And his technique has so far shown that you get quite significant improvements to flap perfusion. So I think this is really interesting. It's never been used. It would be first in the UK study, and then if that went well, we would roll out nationally. Digitally, we're also talking to various digital companies. This is slightly biased because I've shown my own company here, but Concentric produces digital and face-to-face remote, face-to-face or remote digital consent. And there's been a lot of NHS recovery money because of the big 6 million people waiting on the surgical waiting list. And so there's now a big incentive to use digital products to try and help with all this backlog and see how we can use these going forward. So we're a company that has particularly benefited from this. And in the last couple of months, we've signed numerous contracts with different trusts. And I think we're now at a state that we're in so many hospitals have all signed that we could start looking at doing some more national studies. So I hope we can, and so watch this space. Just to finally mention about this, I do have a research fellow advert out to come and work with me. If you're at all interested, it closes in a few days' time, so get in touch with me. Finally, for the clinician innovators, we are a group that you can come and ask advice from. For example, we had someone that was interested about doing 3D printing of implants matched to bespoke for their patients, and we're able to get them in touch with the right people. We're also able to signpost to innovation-specific funding, and often these pots of cash are a lot larger than you would expect with some of the standard research funding, but it often needs a fairly multidisciplinary group to apply for these. So if you want any help or advice, then again, do get in contact with us. If you'd like to join our group, do get in contact. So in summary, we want to be a global resource for breast innovation. We want to be the main link between innovators and industry throughout the innovation cycle. We will host innovation sessions. There is an innovation session at ABS. I'd really encourage you to join that. And we have been talking this morning about maybe running the first iBRA-Net and the first breast surgical hackathon to our knowledge. So this is very collaborative. We need you to be recommending industry to get themselves on our website. We need you to submit ideas. We need you to get involved. Please, if this at all sparks your interest, do get in touch with us. Thank you very much. And I will go straight on, I think, Shelley, to introduce Nadine, who I think is the next speaker. So I can't see my other screen to see if Nadine's on the line yet, but I'll hope she is.
Hi, how are you, Ed?
Hi, Nadine. Great. I still can't see you, but I can see your picture that I put on my little slide. So introducing Nadine. Nadine's a friend of mine, and we joined the NHS Clinical Entrepreneur Fellowship Scheme together back in 2016, I think. But she is the founder of Proximy that has done exceptionally well. It's an augmented reality telesurgical platform, which I'm sure she'll tell you more about. She's a consultant plastic surgeon and the clinical innovation lead at Guy's and St Thomas's. She's spoken at a lot of high profile events. She's got the British Empire Medal. She's on the founding group of We Share Healthcare together with me. She's very impressive, and I can't wait to hear what she's got to say. So thank you, Nadine. I will stop sharing.
Thank you so much, Ed. And I put a comment in the chat, but I really wanted to congratulate you and everyone really on consolidating all these incredible projects and innovation. I'm familiar with a number of them, but the fact that you're sort of taking these forward in a constructive and collaborative way across the group is really, really interesting. So I think many societies can learn from what you guys are doing and the way that you're doing it effectively together. So I'll just share my slides. Here we go. And we do have a little picture of Magseed as well, so we can sort of bring that up too at some point. But thank you for the introduction. And as you kindly said, I'm a reconstructive plastic surgeon. My clinical practice is largely secondary breast reconstruction and pelvic reconstruction. So I do work very closely with the breast surgeons at Guy's and St Thomas's Hospital, which is great, and they've got a great unit there. I'm going to talk to you a little bit today about the challenges that we face in surgery, how I've tried to come across to try and solve or address some of these, but I hope I deliver it in a way that's meaningful or translatable to you. I hope that what I describe resonates with the challenges that you are facing and seeing, and that ultimately what we're designing or have tried to build over the last few years is something that you can find useful within your clinical practice too. And I've been a surgeon here in the UK now for over 10 years in training, and then as a consultant. I've worked for many strategics in helping devise training methodologies and training programs to accelerate skills adoption, new device adoption. But I've also been very passionate about global health and spent about 10 years involved in many countries overseas looking at capacity building and sustainability in surgical care. And I'm sure we could have a whole session on the global south and the challenges there. But the reality is we have a lot of problems in our own backyard, which I think we should probably focus more on today, and the challenges that we face. Clearly, we're seeing an increasing challenge around supply and demand, and that's actually gotten worse since the pandemic because of burnout, because of attrition, churn, people leaving healthcare, and also just the fact that we haven't been able to find ways to give training opportunities to our trainees during that time. And so It's a compounded effect of people leaving, burnout, people not getting trained, and of course, all the backlog that's giving us significant challenges. We have for many years worked in a hub and spoke model, and that works to some extent, but it does create bottlenecks and challenges across the system. And finally, I think what we see, and this is across the horizon, is that as new devices and systems are being delivered into clinical practice, how do we make sure that our clinical teams are competent, proficient, and safe at using these, and well supported through coaching and mentoring to do that? Just in the earlier talk, you've heard about at least 2 or 3 new devices that could be meaningful and could change the face of breast surgery. How do we make sure that that's adopted effectively? I think we were all around when laparoscopic surgery was launched, and I think we learned a lot of what's good, but also how not to launch certain techniques and surgeries. And so we need to make sure that we don't make the same mistakes moving forward. And I think more broadly, whilst we talk about COVID, I think it's fair to say that that just really shone a light on the problem. But the reality is that the current model of healthcare delivery is just unsustainable, period, COVID or no COVID. And that increasing gap that's going to continue to increase across GDP, but also staff challenges, is a real problem that we have to think about how we get in front of. We've already are facing a big burden from that, but hopefully we can try and accelerate or bridge that gap through new methodologies, process redesign, thinking and reimagining the delivery of healthcare through ambulatory models, remote delivery care models, and diagnostics. But equally, how do we connect and crowdsource the knowledge and expertise in a meaningful way? I will just put this slide up because it is dear to my heart, but I think it compounds the global vision of where surgery is that today, 5 billion people around the world lack access to safe surgery. That's 2/3 of the world's population. That is also separate to the fact that people are getting variable access to surgery, which is a different topic. But I think this is highly unacceptable, particularly in areas with oncology and others. This is more than HIV, TB, and malaria combined, but it hasn't really gotten the stage that the others have received over the many years. And I'm pleased to say, at least, that in the work that I'm doing, which we'll talk about, we are trying to make strides and trying to make a small dent in that. We're working with organizations such as Johns Hopkins and Harvard, the Global Surgery Foundation, and others to really think about how do we bring together innovation, technology, and surgery to accelerate the delivery of care. Beyond that, we know that 18.6 million people die because of that lack of access to surgery. And again, I think when those stark numbers are often ignored, but it's really significant. We need to think about how we can try and play a role in changing that. But let's talk about what's going on here in the UK. I talked a bit about it early on, but clearly we have staffing issues. We have workforce challenges. We don't have enough healthcare workers to deliver the care that is needed for our patients, and people are burnt out. We also have huge waiting lists, a record level of people waiting for planned operations. And of course, the specialties that like yourselves work in are necessary when it comes to oncological surgery as well. Important for the care of delivery for patients, hopefully improving their quality or preserving their quality of life as well. And this is a problem everywhere, not just somewhere. And it's important to recognize that it's not that certain pockets of the country face this, everyone faces this. And what we've tried to do a few years ago is we designed a software that really tries to address a lot of these gaps that come in different shapes or forms. I mean, everything I've showed you today, the global challenge number, the hub and spoke numbers, the supply and demand numbers, the issues with backlog now, they didn't just pop up overnight. It's just been a consistent accumulation of the challenges that we have in surgery that have really come to a halt at the moment. And what I thought about is, imagine we took these operating rooms, these highly analog and undigitized operating rooms that we work in. And we've all worked in environments where it's very much about a moment in time. Surgery has historically been designed for that moment in time. But imagine we were able to solve some of these challenges by connecting the dots, creating operating rooms that are connected, collaborative, more data-driven, operating rooms that are immersive, where we can share best practices. But most importantly, we could collect, connect, and activate knowledge in a really, truly meaningful way. And that's about improving access. It's about bridging a knowledge gap and improving that skills deficit, and largely then taking what is highly unstructured data in an operating room. We use different formats. We use an OpNote, there's a whiteboard, there's an EMR system, and there's a bunch of different technologies that we might use. How do we connect the dots and devise one connected surgical care continuum? And I think with GIRF, this is something, I just really like to highlight this, goes that no one should doubt that we all want the same thing. We all want to try and improve outcomes for patients. There's an appetite to try and understand how we deliver that. And For far too long, the operating room has been opaque. Not because it's being obfuscated maliciously, but that's just the environment we've worked in. That's the history of how surgery was designed and devised, and we haven't changed it. But I think we have to take a step back and say, do we want to better understand what goes on in an operating room? And therefore better understand how we deliver the improvement around it. It's not about a big brother approach, it's just about transparency. And if we look back at the genesis of surgery, it was very much designed around communication, collaboration, and co-presence. This idea that we work together around an operating table and we share best practices. And I think I've showed this picture before, but this comes from DeBakey's operating room in cardiology. We haven't adapted to the new world, the populations that we serve, the numbers of healthcare workers that work in healthcare, in surgery and healthcare at the moment. We're still doing more of the same. And more of the same doesn't cut it. It's not going to change all those numbers and the challenges that I highlighted at the beginning. We have to think very differently about how we deliver things. And I was very lucky a few years ago to be one of the commissioners on the Future of Surgery Commission at the college. And we started to really identify what technologies were going to change the future of surgery for the next 5, 10, and 15 years. And this was pre-COVID, of course, but a number of those highlighted were things like computer vision, AI and machine learning, robotics, immersive experiences with AR and VR, but also personalization around genomics and big data. And a number of projects are taking place up and down the country in this space and creating value for sure. And we've seen, robotics take off across the country, as well as a lot of the idea that, AI and data is going to continue to play an important role in shaping the future of where healthcare delivers. And interestingly, in breast, we're seeing a lot of work happening with diagnostic companies, for example, like Kieran Medical and others, with the MIA system, trying to better understand AI and machine learning in imaging and imaging sciences, which has really been the main leader, I think, in the adoption of AI so far. We have yet to see its real value and translation into surgical care, but at least in the upstream diagnostics, we're definitely seeing value. And value is truly about improving outcome and reducing cost. It's not about doing what's trendy. It's not about the next thing, big thing from a technology perspective. The technology is the vehicle or the medium. It's truly about how do we make sure that we are changing or delivering better care to our patients. And so what Proximie truly is it's a software that allows you to virtually scrub in. It's a browser-based, iOS or Android-based cloud solution. And it allows you to dial in from your laptop or your phone or tablet and virtually immerse yourself in any operating room to give a second opinion, to observe or learn, preceptorship or proctorship, to gain best practices, and to crowdsource and consolidate training opportunities up and down the country. Imagine, for example, in breast surgery, you had Proximie set up in all your operating rooms, or at least some of the key training centers. How amazing would this be for deanery trainees and others to be able to dial in to any surgeries around the country, to learn, increase their volume, to access, to support their decision-making, which is as much of an important part in surgical training as it is to actually do the operation yourself. Every case is then recorded into a library, and you now can use that library to inform best practice, to give feedback to the trainees, more of a video logbook approach. And there's been a lot of evidence that's shown that video performance metrics play an important role in accelerating learning curves and reducing harm to patients. We can take up to 4 feeds from any operating room, and we take care of all the hardware, software setup. We simply need access to the Wi-Fi, and we go through IG with every hospital. And we're working in many hospitals in the NHS already, but close to 500 hospitals globally. And because you're able to get many feeds, it's really important from a learning experience that you're looking at human factors. You're looking at the scrub table. You may be looking at any relevant imaging, pre-op or intra-op that's necessary for the operation as well. And these are not breast cases, but it gives you a bit of an example of what may be relevant in an orthopedics case or what may be relevant, for example, in an interventional case. And that's really the idea behind that, is really building the engine that enables you to capture information, share that information, and take it forward. Really shifting a see one, do one, teach one to a prepare, perform, and perfect. And I have a bit of a highlights reel that's just going to show you the use of Proximie across a number of specialties. And we do work with a number of medical device companies in helping them scale training, because we've demonstrated that we can really accelerate that learning curve as well. And I'll show you some of the evidence shortly. What's important to me is that Proximie's platform is used all around the world. Whether you're in the most advanced teaching hospital in the center of a big city in the US or in the UK or Europe, or you're in a small community hospital in an area that has one specialist across the whole population, we need to all be able to have access to that solution. Imagine that connected surgical care continuum, pre, intra, and post-op. Solutions and technologies coming together, integrating across an OS, and Proxima being that OS of the operating room, enabling connectivity, collaboration, data and analytics and intelligence, turning these rooms into smart ORs, taking surgery beyond the operating room.
And we have 69 different countries, so it's such an honor, and thank you, Proxima.
So again, we've got the globe covered, and we're all in the same room watching this procedure.
I tend to put two, and this one, I mean, just from a gravity standpoint, I'll stick on that so-called gutter if you want, and then this side I'll put on the other gutter.
Okay. The one thing, now that I have an annotation device, which I love,
oh wow, I love it. I wish it was your real hand.
Yeah, so that if the patient is twisted in a left-sided position, that you know where 6 o'clock is. Yeah, so that if the patient is twisted in a left-sided position, that you know where 6 o'clock is.
So this is the plane. Here is the pancreas.
Ah, yeah, just a little wink of it.
It's our friend.
Yeah.
I always say the pancreas is our friend because it always gets such bad press in the colorectal world.
It is a very sophisticated technology, but very much user-friendly, particularly for somebody like myself who gets scared about new technology because of my age, really.
Actually seeing and testing the model, I just thought that it was an amazing tool. We need something like this to help us advance our skills, to help us continue to perfect our work.
This is a really common thing that you see with MSAPs, is that it comes up through the muscle and then traverses across the muscle before going up into the fascia.
With Proxima, I've been using it really heavily since May. I was introduced to the technology during COVID, and it's just been a game changer. I am able to, every time I operate, have another surgeon in the room.
No bubbles. Suck and get out. We are done, ladies and gentlemen. 7 minutes ahead of time. Thank you so much. Go ahead.
And so what we've been doing is running programs also for specific specialties such as urology, where we run events where they're able to dial in for preceptorship and proctorship. We've even been doing it for medical students across KCL, where on a weekly basis, they're able to dial into cases and get better understanding. We also provide support during cases where you might want to bring in a multidisciplinary partner. If they're not on site, could they dial in? And of course, a personalized video library, which could either be for a society or for a deanery or a particular hospital as well. And we're doing some work with Health Education England now too. And the use cases, of course, are vast, from managing a hub and spoke model, registrar trainee training, remote education, live case observation, the library, but even clinical trial support. If you're deploying a new device and you want to better understand how it's being used by the clinical teams, this is a great way, rather than turning up, having to travel, sit in the coffee room, wait for the case to be used, to just dial in when the case is needed. And it's really taking us from a see one, do one, teach one to a continuum: prepare, perform, and perfect. Because no matter where we are in our surgical career, we will continuously go through that challenge. And it's really important to continue to have that journey documented, digitized, and captured through one interface. And we've already provided and published quite a number of papers that have shown, improving efficiency and outcomes, speed to access and training, improving quality, of course, reducing the need to travel, which has a carbon footprint impact as well. Really important these days as we talk about sustainability as well. And we've shown that we can train twice as many surgeons in half the time whilst maintaining quality. And we have some great studies around the world where we start in one OR and suddenly the hospital wants to put it across every OR and in their sim lab to really provide a single digital platform that connects all their rooms and gives access to their consultants, their trainees, their medical students. And this is a consultant who's enabling his fellow to do some training, but is sitting out to give him a bit of that independence and comfort whilst keeping a close eye and support and mentorship. And we've had different consultants, even like Stella Vig, that have really found this is a useful tool to train some of their trainees in some cases too. And we can integrate in any hardware in the operating room, from a headset camera to a compact set, to a console, to an integrated room, if you so happen to work in one of those. I know they're rare, but nonetheless, we can plug into them. And we truly believe that this is a systems change, and digitizing the operating room is now, the time is now and is necessary. And we're trying to continue to push the envelope with new devices, with headsets, with combining work with telco companies like Vodafone to enhance our global web of connectivity, and as well to sort of start to think about image recognition and other technologies that we can bring into this. And we've done some work around colon cancer, but very excited to continue to do research around other specialties. For anyone who's interested, please do reach out. We're also starting to better understand the operating room and the effectiveness of an operating room. Given we are recording, can we start to help hospitals better understand what goes on in the room, work together effectively, and try and find pain points in how we can address the backlog and try and make the most effective use of the operating room time as well. So we're going to look at how we continue to extend that possibility, and we're doing some initial discovery around this at GSCT, but very early days, and we look forward to doing more studies around this as well. I know we're getting sort of close to sort of the lunch break. Perhaps people might be ready for a coffee break, but I thought I'd keep it short and happy to take any questions if there are any. Thank you very much. And if we can be of any help to your deaneries, your trainees, your society, or even on any of the device trials, please don't hesitate to reach out to us.
Thanks so much, Nadine. That was a tour de force as always. I'd encourage anyone who's got any questions, now's your time to ask Nadine. You won't always have her online ready to answer. But Nadine, have you had this used for breast surgery, supporting third world countries or developing nations for breast surgery yet? I know it's been used for quite a few other specialties. I just wondered.
Yeah, we've been using it at Guy's for breast. We've done some work with Ash Qatari and Hisham Hamid on some of the devices here, trying to see how we can connect even across country, let alone cross border, even proctoring on some of the new systems and devices. So we're definitely have entered breast, but we still want to do a lot more. And then separately in the global south, what we initially focused on was safe obstetric care. We're now extending into cervical cancer, but would also be delighted to explore any supportive opportunities in global health and breast as well. But I think there's a lot of opportunity even here in the UK as we connect hospitals and trainees with more opportunities. I think we definitely have missed that, and being able to leverage that here is going to be really important as we try to scale up our registrars and our fellows to be consultants very soon. Ultimately, they're going to be looking after us, so we need to make sure they get the best training that they can.
No, absolutely. And I was just thinking about Rajiv, because I know he does a fair bit of work in Kenya, but I can't see him on the line.
We work in Kenya actually quite a lot. So if there's any interest, we've got some really great support with the Ministry of Health, with the local, with Johns Hopkins group, which is on the ground, which does a lot of work there as well. So we've done Kenya, we're moving into Tanzania and Rwanda as well, and looking to do more work in Africa for sure.
And has it been used during the conflict so far? Is it any roles there?
We have had some discussions we're trying to support, but what I can say is the UK military uses Proximie as well. So we have a relationship with the UK MOD. Fantastic.
And then I think, you know, as you alluded to, it would be a very nice system for some of our iBRA-Net sort of device evaluation. So I know Shelley Potter put in some work about feeding back what you've learned with your product you're doing, and how do we most effectively learn from each other. But having videos recorded and having sessions like this, I think that there's clear scope there. So I'm just having a look now to see if there's any questions. I'm not sure if I can easily see them. Shelley, do you have any?
Yeah.
Shelley, is there any questions or anything you want to wrap up your side?
I can't see any questions, but the potential for this and training and things like LICAPs and things, just amazing opportunity. I know that we've got some trainees on the call who would probably be really, really interested. That was a fabulous talk, Nadine. Thank you so much.
Thank you so much. I've dropped an email address in there anyway. If there's any interest or if we can help set you guys up for any training, please don't hesitate to ask. And if we can link it into some of the HEE work as well, that would be a plus too.
Fabulous.
Yeah, and I think from my point of view, you're a bit of an inspiration, Nadine, but for all the listeners, if you've got an idea, you can make it happen, and you can think outside of the box. I think traditionally surgery, we've often been quite narrow in our actually, I guess the main message is that you don't need to be narrow, open your minds and believe.
Absolutely. And I would say there is no better time than now. I think the pandemic has really shone a light on the importance of innovation and entrepreneurship. Also has really celebrated clinical innovators. And I truly believe that, we can innovate from the front line. It doesn't have to be big companies that come and tell us what we need, but we as healthcare workers have the opportunity. We see the problems firsthand. We know what's going to work for us, and we can be quite creative in trying to solve for them. It's also been really exciting from a career perspective to start to see so many hospitals starting to really embrace the kind of clinical innovation lead role. When I started a few years ago, I think I was the only one who'd received that, or there's probably also Ian up in Alderhay, the only two really who had that role where the trust was almost paying for half of your time to be covered to just look at innovation. I just caught wind of another colleague of mine who got that role last week as well at a hospital in Oxford. And I think we're starting to see more and more of that. And that gives you a bit of an edge. If you're a trainee, you have a thematic interest in innovation, build it, hone it, because a lot of hospitals are going to be wanting to hire innovation leads or roles within innovation as well. Just like they used to hire the academic surgeon or the surgeon who likes management or teaching and education, there's now a role for the innovator surgeon. So it's a great time to hone that skill and make that a kind of USP for you at your application process.
I completely agree, and very well put, Nadine. Right, well, look, thank you very much.
Thank you so much for listening.
No, thank you. And we're heading towards lunch. Shelley, I'll leave you to wrap up.
Lovely. I'd like to thank Ed and Nadine and also Jenny. I think this session has been entirely about thinking outside the box, and I hope you feel suitably inspired and ready for lunch. So we're a little bit early, but I think that's probably a good thing rather than running late. So if you want to join us back for the mammary fold session at 2 o'clock, that's right, Jenna, isn't it?
Yeah, that's right.
So have a lovely lunch, and we'll see you back in just over an hour's time.
Thanks, Shelley.
Thank you for a brilliant session. We'll see you soon.
To start the afternoon. So good afternoon and welcome back to this joint iBRA-Net and MFAC Academic and Research Day. So I hope you're all nicely rested and ready for an exciting final session this afternoon. So this is the Mammary Fold Academic and Research Collaborative session, and we've got a selection of excellent talks for you this afternoon, all from trainees from around the country. So for those of you that don't know, the MFAC is a subcommittee of the Mammary Fold, which was developed in parallel with the ABS Academic and Research Committee back in 2012. And as a group of research interested breast trainees, our aim is to facilitate UK-wide trainee promoted and/or led research. And you can find out some further information about who we are and what we do and how to get involved on our web pages on the Association of Breast Surgery website. So this afternoon, we're going to start the session with our study updates, looking at past, current and future projects that the MFAC are involved in. I think some of our speakers are dialing in between clinical commitments. And so if anyone does have any questions that they would like to ask our speakers, I would ask you to please write these in the chat or question and answer function at the bottom of the screen. And we'll try and ask these at the end of each talk. So our first speaker this afternoon is Alona Courtney, who is going to talk about the MAMA project that was run through the MFAC. And Alona is an academic clinical fellow in general surgery at Imperial College, and she is the asset representative for the Mammary Fold and was a steering group member of the MAMA study. So Alona, I'm going to hand over to you now.
Thank you very much. So I'm here just to give you a quick update about MAMA, which is a UK and Ireland-wide mastitis and mammary abscess management audit. Just to give you a quick update. So the background of this project is that it's mastitis and breast abscesses are obviously a very common benign condition that affects both breastfeeding and non-breastfeeding women. It's commonly managed by non-breast specialist general surgeons because patients tend to present out of hours. And prior to this project, there was some evidence of significant variation in practice. However, we haven't had any concrete evidence to actually base the guidelines or update the guidelines on. The consequences of inappropriate treatment can obviously be quite significant. If we give inappropriate antibiotic, we can ultimately result in significant infection and hospital admission. If we admit the patients inappropriately and they're breastfeeding, then it can result in separation of breastfeeding mother and the baby and obviously affect their mental health. And if we perform incision and drainage unnecessarily, then that can result in cosmetic disfigurement. Moreover, we know that inpatient beds are expensive and the cost of benign breast infections is about 3 million. And if we perform any interventions such as incision and drainage, then the cost rises to about 10 million pounds, and that's old costs. There are obviously barriers to optimal management, such as presentation out of hours, lack of experience in frontline staff, absence of unifying protocols, including antibiotic prescribing, limited access to interventional radiology to perform aspiration, and inappropriate patient follow-up. So the aim of MAMA was to describe the current practice in the management of mastitis and breast abscesses, and then to advise on improvements in the current guidelines. And the guidelines at the moment are very old. There is WHO guideline on mastitis, which is from 2000, and there are also Northern Ireland guidelines that are quite out of date as well. So MAMA was conducted in is due to be conducted in 3 phases. Phase 1 and phase 2 have been closed. Both phase 1 and phase 2 were run concurrently. Phase 1 looked at the patient pathways and was a practice survey, and phase 2 was a prospective audit. You can see the inclusion and exclusion criteria. The data collection ended for phase 2 in September last year. The results of phase 1 were presented to ABS conference last year, and in summary, this is what we found. 80 hospitals participated in practice survey and have given us their expected management of mastitis and breast abscesses. 77% declared that they had a local hospital protocol. The anticipation is that most patients are managed by breast team in hours, but out of hours, the care was lacking. Breast ultrasounds were performed in all patients, in 2/3 of the patients, but in selected number of hospitals, they only performed ultrasounds in certain patients. We anticipated that majority of patients had ultrasound guided aspiration, but again, this is what we think we are doing rather than what we are actually doing. And we anticipated that only 2.5% of patients would get IND as their primary mode of treatment for an abscess of the breast. And we thought that most patients were managed in an outpatient setting, with admission for criteria being severe infection and hemodynamic instability. And criteria for IND was the most commonly cited was skin changes and necrosis, as well as a multiloculated abscess. From phase 1, the most important areas for improvement were to improve direct access to breast clinic and to radiology for urgent aspiration, to ensure that we perform proper follow-up of all patients to avoid missing inflammatory cancer, to clarify selection criteria for hospital admission and incision and drainage, and then to facilitate dual admission and breastfeeding support, as that was one of the areas with very poor provision, and very few hospitals provided dual admission. Now, phase 2 70 hospitals participated in data collection. We had excellent results. So we've had 1,370 patient data entries, of which only less than 3% were excluded. These are the reasons for exclusion. Now, as the results of this study have been entered to both ASBRS and ABS conference, I think it would be a bit premature for me to tell you exactly what the findings were, but the conclusions were that the access to breast steam out of ours was, as anticipated, quite poor, and the breast steam follow-up seemed to be varied and significantly different depending on what diagnosis the patient had. There was significant lack of uniformity in antibiotic choice and certainly inappropriate prescription in terms of the course of antibiotic. Location of treatment was much higher as an inpatient treatment rather than as an outpatient than we've anticipated. And the rate of incision and drainage, which was much, much higher than they predicted, 2.5%. And that obviously is an area for improvement. And that's the end from me. There is a question? No questions.
Thank you, Ilona. That's brilliant. I haven't got any questions that have come up yet. So has anybody got any questions for? So there is a question from Kit. So she acknowledges very important work and well done. It's lovely to see some results coming out from the MAMA project. How are you planning to implement these results?
So we obviously need to update. I mean, first of all, we need to actually have some national guidelines, not Northern Ireland and WHO guidelines. And we have already started working with ABS on updating the guidelines. Now that we have some solid results, we can update the guidelines and issue national guidance as to how we should be treating it. And we will also outline hospitals that are performing higher rates of IND or that are not performing enough follow-up, for example, and address that directly with the hospitals. And then the plan was always to try and see if we can continue with the audit on a yearly basis to ensure that patients are receiving appropriate treatment. So if we can get enough support from trainees, then we'll continue with that.
Brilliant. All right. Well, thank you for that, Ilona.
Perfect. Thank you very much.
No problems. Okay, so our next speaker is Lisa Sheehan, and she's going to update us on the NUN study. So Lisa is a general surgery trainee and as well previous chair of the Mammary Fold Academic and Research Collaborative and is the lead for the NUN project. So Lisa, if I can ask you to share your slides if you have them, and I will let you take the floor.
Hi, thanks, Jenna. Hope you can hear me. Let me.
We can, thanks, Lisa.
Okay, so hi everybody. I hope you're enjoying this year's academic and research day. So I'm just going to share with you, I've done 2 studies recently with the MFAC over the last couple of years. The NUN study is something that if you've been previously watching before, or you might even be involved in it, I just wanted to update really. So for those of you who don't know, the NUN study is about the unilateral nipple discharge study. We're interested in it because we don't actually have good evidence about how to manage unilateral nipple discharge, and current guidelines, ABS brought out some guidelines just over a year ago or so about how to manage this, but this is actually based on fairly poor quality studies, and we're not actually sure, even though we've got some anecdotal evidence about the linkage of this symptom to underlying malignancy. If you look at the literature, it's anywhere between 5 and 18%. So we were hoping to get a better idea of what the true value is in our patient population. So we did actually a pilot study a few years ago in the Wessex region, and I'm just for time purposes, I'm not going to go through all this in detail, but ultimately we looked at how people were managing nipple discharge in a few hospitals within the Wessex region, and how they were being investigated. Very few people are sending off cytology still, but it's interesting to know that it's still being used. And ultimately, just to kind of get to the summary of the findings, we found 4.4% malignancies in our patients, and we had about 225 patients or so. So that kind of is related to what the NICE guidelines or the ABS guidelines are trying to capture in the patients that we're seeing with this symptom. And 5.7% of those patients had papillomas. The malignancy wasn't detected by imaging, but the patient did have abnormal cytology, interestingly, and the 6 papillomas weren't detected by imaging, but 2 had blood on cytology. And there's potentially lots of patients who are being investigated for benign discharge, including having surgery. So, you know, duct surgery and the potential morbidity that's a consequence of that, and perhaps they don't need it at all. So we've been running the National Unilateral Nipple Discharge Study since just prior to the COVID outbreak. We were aiming for 2,000 patients, and we're still aiming for that. And the idea is to produce an updated national guidance based on some evidence that we've got from questionnaires and data collection. It's a prospective study that we've been running, and it's all the data is entered into a REDCap database, and then we will analyze that. So this is roughly what the questionnaire looks like. We ask that patients are identified in symptomatic clinics, and then essentially you write down pertinent points from their history that we're interested in, and how you're managing them, and if they go on to have surgery, what the final outcome is. So this is been well publicised and promoted by the Mammary Fold Academic and Research Collaborative, and we're getting there, but we're asking each data collector to collect at least 30 patients. But to be honest, because of COVID and all the pressures, if you are managing to recruit, or if you are managing to collect data, we're asking if you could just collect as much data as possible to get this study finished as soon as possible and get it analysed. There are understandable reasons why there's been massive delays, and so far we've had 450 patients in the REDCap database, and when I looked earlier on today there were 520, so we're roughly at 25% of our target. 30 units have signed up. We do have 5 top runner hospitals, so thank you so much for anyone who's actually contributed so far, and we're encouraging everyone to keep collecting for us, please, to reach our 2,000 patient target. If we don't reach that 2,000 patients, we think that we won't get the statistical significance, and of course if it's not statistically significant, then the value of the results is questionable. So we want to hopefully get to our target. So please help us with this study if you can, and if you've already collected data before, then there's absolutely no reason why you can't do that in another hospital or carry on. That would be amazing. So that's my email there for the NUN project, nunproject@gmail.com. Please get in touch, or the primary investigator, Sarah Clark. The email address is there, but it's also on the mammary fold pages as well. So that's NUND. And this is an unpublished study, but we also ran this through the Mammary Fold Academic Research Collaborative, and it's just waiting to be published. So this is raw data that you're looking at, but this is also activity from Mammary Fold over the last year or so. So ALCL implant questionnaire. This was the whole idea behind this project is, are we really giving patients choice with regard to choosing implants? Are they really informed about anaplastic large cell lymphoma? And we decided to do an audit of practice standards relating to implant choice, about informed consent and using breast implants for breast reconstruction. Our hypothesis was that despite the ABS national guidance, there's variation around the country on choice, information and informed consent, and there's also likely to be variation between private practice and NHS work, mainly because there is a large difference in the work, benign versus malignant disease.
Lisa, we can't see this current presentation. We can only see the NUND presentation.
Oh, sorry, excuse me. Is that better?
Perfect.
Sorry. Yes, so this is about empowering patient choice. As you would have heard of the case law Montgomery versus Lanarkshire 2015, we are urged to consent our patients by giving them all the information that they require to make choices, even if you consider the risk small, but it may have a large consequence for these patients. You have a duty of candor as part of the consenting process to share that with them. And so that is an important point. And so we were looking at that as well. There are a number of guidelines for clinicians with regard to ALCL. ABS have their own statement, BAPRAS do as well, and there's also a UK government page as well. So we did an audit of practice questionnaire. We sent this out via social media between 2020, December 2020 and August 21. So it was a good 8 months. And we sent this via our Mammary Fold communication channels. It was all anonymous contribution, and we asked trainees to fill these in on behalf of consultants or share with them if they didn't feel they were able to fill that in for their consultant. So we had 76 responses in total. And this is just a pie chart to show you that actually it was from all over the country. So we've got a good spread of contributors in the whole of the UK. And so we asked when consulting a patient regarding implant-based breast reconstruction, do you offer the following type of implants? So there were certainly some preferences. So silicone was preferential, as was textured implants and anatomical, but there was a good variation as well. And we asked whether the implant choice was actually defined by what the hospital offered, and there was actually a large percentage, 25% said that yes, there were barriers, they didn't have control over the implant choice that they offered. If patients did choose, did they have preferential choice of certain implants? And so patients seem to not really be that bothered about whether they chose saline or silicone. But they often patients weren't given a choice, and smooth or textured. So often patients, 47.7% weren't given a choice about their implant. And with regard to anatomical, most patients were choosing anatomical implants. But again, a good percentage weren't offered. Is the implant usually the surgeon's choice? Overwhelmingly, it is the majority that is the surgeon's choice. And does the surgeon have a particular preference for type of implant? 50% said yes, and most people who said yes then went on to said that they prefer anatomical mentor implants. Interestingly, ALCL hasn't changed practice for a lot of surgeons. And mentor seems to be the overwhelming preferential brand that they choose. And we asked whether they tell patients about the risks of ALCL in terms of quantifiable risk. And if yes, what quoted instance do they state? And we offered a multiple choice of instance, and there was actually quite a wide variation. Most opted for the 1 in 21,000 to 1 in 50,000, but there was actually a wide choice, as you can see in that pie chart, of different incident rates quoted. Do you give patients written information on ALCL? Most patients don't get written information, it looks like. And where do you obtain your information sheet? So most of the information seems to come from locally produced guidance. We don't know what that's based on, but it was quite interesting to get these quotes because the ABS guidance document isn't the most widely shared with patients or the official BAPRAS. And this is just again narrowing down exactly what patients are being provided with, and implant company information sheet seems to be the one that's chosen, but it's conjecture about why those methods are chosen. Perhaps it's more easily available. On the whole, do you think your patients seem to be concerned about ALCL? So, interestingly, few patients seem to be concerned about ALCL from this questionnaire, which I think that's quite an interesting point, because you'd expect patients perhaps to be concerned, but and it says 9.2% of patients aren't concerned about ALCL at all. So you wonder if they're getting the information that they require, or perhaps they don't think that that's particularly important with regard to their overall treatment. Further evaluation and further studies would have to be done to find that out. Do you carry out cosmetic surgery in the private sector? So most of the people contributing to this, most surgeons were purely NHS surgeons and didn't carry out any private practice. If you did carry out private practice, do you offer the same degree of implant choice to your NHS constructed patients as to your private patients? And actually the answer was 60% didn't offer the same choice. Have you ever had a case of ALCL diagnosed in your unit? Most surgeons said they haven't, but actually there seems to be a fair amount of experience, with 34.2% having experienced at least one case. And then we asked about the management of late onset seroma, and to look at if there was variation in practice with regard to this. So if a patient develops late onset seroma, what imaging do you do? So actually 73.7% follow the national guidance of an ultrasound and MRI, but 26.3% requested an ultrasound only. In patients with implants and late onset seromas, do you always ask for fluid to be sent off for diagnostic markers? So the overwhelming majority said yes, but there was a large variation in the diagnostic markers that they did choose, and there might be various reasons for that, but it's an interesting point. It's interesting to know whether or not guidance is actually being followed. It might be that the pathologist is relied upon to ask for the specific markers. Were you aware of the MHRA yellow card scheme for reporting ALCL? So as anyone who's looked in the back of the BNF will be aware of this yellow card, and it can be reported online these days, and you're supposed to report any instance of ALCL via this channel, and 26.3% of respondents weren't aware that they were supposed to report ALCL through this way. When you see a patient with an implant in clinic, do you give them safety netting advice to represent if they develop a seroma beyond a year? And actually 30% weren't given safety netting advice. Does the risk of ALCL reduce your enthusiasm to recommend implant-based reconstruction? And most people said no. So 34% said they had experienced ALCL. And so that's so only 11% were saying that they would change their practice. So even if you've had, it seems that even if you've had an instance of ALCL in your practice, it wouldn't necessarily change your future practice. Does ALCL have an impact on your follow-up plans for patient with implant-based reconstruction? And actually most people said no. So coming to the conclusions, there's a wide variation in practice with regard to the detail of consent, it seems. There are definitely limitations of this questionnaire, but it highlights some important questions, and there might be some further evaluation that's required of surgeons' practice with regard to ALCL and consenting their patients. Or do they feel that their patients are being truly informed of the potential consequences of using an implant? And even though there's a high level of awareness about ALCL amongst breast surgeons, it seems that there's not necessarily the same awareness about following national guidance. For example, the lack of awareness about the MHRA yellow card scheme. There's questions about whether surgeons and patients should have full control over implant choice. Does it really matter? Should the hospital be influencing implant choice? And is there any evidence behind the surgeon's choice behind brand of implant? Many patients don't seem to be offered a choice for one reason or another, and it seems to be largely still the surgeon's choice. Maybe that's the correct decision, but perhaps it needs to be discussed, and whether patients should be getting a bit more say in what stays inside their body. And 63% of patients aren't provided with information leaflets on ALCL. So you wonder if those patients would be informed and whether they would flag up any symptoms in the future. So essentially, yeah, there's a wide variation, and perhaps we need to think about the management, change our management slightly with regard to all of this, especially as new evidence seems to be coming out, and guidelines are being updated all the time. It's important to stay it's important to stay updated and relevant with current guidelines. Okay, thank you.
Thank you, Lisa. Really interesting. It's nice to see those findings. Again, I don't have any questions in either of the chat functions, and I think we've got a fair bit to get through. So I'm going to move on to our next speaker. So our next speaker is Catherine Fairhurst, who is going to talk about some of the new projects that MFAC are going to be hopefully involved in. So Kit is an NIHR clinical lecturer in surgery at the University of Bristol, and she is an MFAC committee member and our secretary. So Kit, I'm going to pass over to you.
Thank you, Jenna. Okay, is that all good?
Looks good, yeah.
Brilliant. Okay. So thank you for the kind introduction, Jenna, and the opportunity to present Diamond, which after this morning's fantastic talks about innovative research methods aims to be a humble randomized control trial of drains versus no drains following mastectomy and axillary surgery. So I'm a clinical lecturer in breast surgery at the University of Bristol, as Jenna said, and I'm co-developing this work with Shelley Potter, who you'll all have seen this morning. So, as I'm sure most of us know here, drains have been used following mastectomy and axillary surgery for many years, with the primary aim of avoiding seroma and consequently wound healing complications. However, whilst inserting a drain is generally a minor issue for surgeons, it can be a cause of much anxiety, discomfort and concern for patients. And this can result in a poorer patient experience and the prevention of same-day discharge. And of course, the associated costs of the hospital stay and additional healthcare provider interactions. So the literature has lots of small single centre studies and RCTs, and the two most recent systematic reviews shown here have demonstrated that whilst drains do reduce seroma rates, they do so at the expense of longer hospital stays. Obviously, the data in these studies is quite old now, and a lot of us do day case mastectomy, but nevertheless, these are the findings. And in addition, the data that was included in these reviews was found to be methodologically flawed, heterogeneous, and the most common outcome of primary outcome of seroma being poorly and inconsistently defined. And this has limited the usefulness of their findings, and as such, further RCTs reflecting outcomes of importance to patients were recommended. So there are two ongoing trials evaluating the use of flap fixation to reduce seroma formation following mastectomy. The Quiseramus trial is a 4-centre French trial, which is now closed but not published. And the SARA trial is a single-centre trial in the Netherlands, which is currently still recruiting. The issues with both of these trials in terms of the Diamond study are that they're small and single or few centre trials. Both still have a very subjectively measured primary outcome of symptomatic seroma. Patients having axillary node clearance are included in the Quiseramus trial only, and if this occurs in either of the randomised groups, a drain is still used, and they describe in the protocol that they close the axilla with sutures, and therefore only the axilla is drained and not the mastectomy wound, which I think most of us would be a little bit suspicious about. Flap fixation is not widely used in the UK, and some surgeons have concerns about loculated seroma developing, as can be seen, or it's often seen on the back when we quilt after an LD reconstruction, and this is even harder to drain and worrying if it gets infected, and the potential effect of suturing on the skin flap blood supply as well. And importantly, both these trials are designed to answer if flap fixation reduces seroma rates, not if drains are necessary at all. So we've done some feasibility work, which hopefully some of you may have taken part in. So there was a national practice survey distributed by ABS and social media to UK breast consultants and senior trainees. That was open for 3 months. We've received almost 100 responses, and we also completed some focus group work with patient groups in Bristol and with our 2 independent cancer patient voice co-applicants who are both breast surgery patients. So first of all, the survey work showed that 85% of those who completed it used drains either routinely or some of the time. 67% of those who don't use drains routinely don't perform flap fixations, bit of a tongue twister that, demonstrating that this is not a widely used technique in the UK. 65% think there is a need for a trial, with 12% thinking there may be. 73% thinking a trial is possible, and a further almost 21% thinking there might be, it might be, and 60% were keen to recruit, with nearly 20% again thinking that they might recruit. As such, we think a trial is likely to be feasible in the UK. So the main issue with the design of this trial has always been the primary outcome, and I've talked about issues with historic and current trials using symptomatic seroma, which is potentially very subjective and not particularly patient-centred. And the feasibility survey therefore asked surgeons what they felt it should be. And unsurprisingly, the most obvious choice was still symptomatic seroma, as this is the main proposed reason for using a drain. But the second most popular was the number of hospital visits. And when we explored these outcomes with our PPI groups, the number of hospital and care episodes also came up as a trial outcome, because patients found that visiting the hospital for drain issues and having the drain removed and contacting their breast care nurse with problems and so on was a significant inconvenience in their recovery. Other potential outcomes came up again, including seroma drainages, complications, anxiety, patient experience. And one patient actually mentioned cost. And of course, this is something we do wish to measure. So the primary outcome for the trial is planned to be the number of hospital care episodes in the first 2 months post-surgery. And we think this is a measurable hard outcome, which is indicative of both the cost and implications of having a drain to both patients and the NHS. So the trial hypothesis is therefore that not having a drain after mastectomy and axillary surgery results in no more and likely fewer hospital visits than having a drain, and that patient experience will be much improved by having a drain with no increase in wound complications, and that not using drains will be more cost effective both to patients and the NHS. So our next step is to put in for HTA funding in May. And if successfully funded, we hope to deliver the trial via our very own Memory Fold trainee collaborative and utilising the associate PI scheme, which Tim's going to talk about next. We think this trial will be simple to recruit to and to deliver, and it'll allow breast trainees nationally to get involved and learn how to recruit to randomised trials, and most importantly, answer this age-old question as to whether drains are necessary following mastectomy. So thank you for listening. Please find us on Twitter. I've put our handles there and the email address for the study as well. And do get in touch if you'd like to be involved, and we'll let you know whether our funding's successful.
That's brilliant. Thanks, Kit. So really nice study. That should be very exciting to run. Again, I have not had any questions, so I am going to move right on then to Mr. Tim Rattay, who is going to talk about getting involved in collaborative studies with the MFAC and a little bit about the NIHR Associate PI scheme. So Tim is an NIHR clinical lecturer in breast surgery at the University of Leicester and is on several national academic committees, including our MFAC, as well as the ABS Academic and Research Committee and the iBRA-Net executive committees. So without further ado, Tim, will you take it away, please?
Yeah, thanks, Jenna. Can you hear me now?
Yes, Tim, we can, absolutely.
Yeah.
Thank you.
So yes, I mean we've got about this morning and this early afternoon we've heard about so many great collaborative projects and innovative projects that have come out of iBRA-Net and also of the MFAC work, and we've also heard about a new proposal from Kit. So how can, and this morning from Beck Kim, which is the Mareka study. These are just a couple of examples that are currently being worked up or starting. So how the title of this short talk is about getting involved. So how can you get involved, especially those trainees who are listening in? So clearly there is an incentive to get involved in research because it is a CCT requirement, both in the old curriculum and in the new curriculum. It's a little bit more woolly, but there is still a requirement to show evidence of being involved in research. And getting involved can in research as a trainee can also build future research capacity for surgery in the United Kingdom. Trainees are generally well connected regionally, and as such, are well placed to conduct multi-center studies, as Lisa suggested, even in one place, and then if they move on, they could do the same in another place. We've got trainee associate specialty study leads in place, which are funded by the Royal College. These work with the specialty study leads, which are consultants, academic consultants often, who are funded by the Royal College as part of the Royal College Research Initiative to drive up the number and the quality of surgical trials in the UK, and also the share of research funding that's obtained by surgeons by surgery. And as part of similar to the Associate SSL scheme on a local level for individual studies, we've last year, with some slight delay, the NIHR launched the Associate PI scheme, which basically means that we have a trainee who is working alongside a local PI, which is usually a consultant in a unit, to deliver a study. I don't have to go, I can only reiterate again the benefits of collaborative research, both to the individual, as I've just said, which enhances their CV, helps with publications and presentations, but also to the quality of research and to patients, because we, as Lisa has just nicely illustrated, a local study of nipple discharge in her unit, one of the units where she worked, wasn't powered enough to deliver any significant answer the research questions that she was asking. Hence, she decided to propose this national audit, which is, although it's slowly recruiting, hopefully she'll get the numbers, and hopefully some of you will get involved and in help her achieve these numbers to answer the research questions about nipple discharge and the management of that. In my role as the Associate SSL, I was appointed about 2 or 3 years ago now. I'm just putting this out there in case, as obviously at some point I will be demitting this role, and somebody else might be interested in it. It's really to support as I said, the Surgical Trials Initiative, and deliver and both personally learn about the conduct of clinical trials and take part in TMGs, but also to champion research work amongst other trainees, other breast trainees. And our current, as you can see on the photograph there, our current SSL is Stuart McIntosh, who was a surgeon, an academic surgeon, a breast surgeon at Queen's University Belfast. So the Associate PI scheme is a national scheme from the NIHR, and it runs over 6 months, basically. You have to be in post for at least 6 months in your unit. And the idea is that you deliver a registered NIHR portfolio study under the mentorship of your local PI. And any study, any portfolio study, which means a study, whether it's a trial or observation study that's registered on the NIHR portfolio, and hence gets the support from the research networks within the hospital, research nurses, etc., can apply. But you can't register a study retrospectively. So you need to get your PI or the CI of the study, of the main study, to register the study, and then you can apply yourself as the applicant, as a trainee, to be the associate PI in that unit. And you basically, it's a bit like a training log. You have to basically complete a checklist by the end of your 6 months and complete some training on the NIHR Learn platform. So that, and then you get a certificate at the end, both that you've taken part in recruitment and driven up recruitment, hopefully, at your unit, but also that you've gained the relevant experience. This is good for your CV, but also for future research activities, either as a trainee or as a consultant. And work from the NIHR, early work on, for example, the very large multi-center recovery trial, which is part of the COVID management, has shown that at over 90% of trainees who are in the API team remain interested or remain engaged in research activities, and there are currently over 300 studies to select from, to choose from. And as I said, this is open for anybody to any other study to register, provided it passes the NIHR criteria and it's on the portfolio. So these are just very briefly, these are the study eligibility criteria. This is more really geared towards the PIs or the CIs. But if you are interested in becoming an API for a study and you finding it's not on the portfolio, this is a reminder really. And you could push your PI or a local PI or even the CI, this chief investigator of the main study, if it's a multi-center study, to put this study on the API scheme. And they can join the API scheme within a few months of recruiting, but not earlier than that. And it's not open currently to fully funded commercial studies. So you can only be the API for one study at a time, and you can only have one API per study per site. You may not be eligible if you are, for example, a research fellow appointed under a grant for a particular study already, which means you have specific research funding, or you are, like myself, a clinical lecturer although there are some exceptions, and you can, if you want to do the API scheme, nonetheless, you can write to the, you can negotiate that with the API team at the NIHR, and the web address is given below. And the important thing is that you need to talk to your local PI beforehand, and all this needs to be done prospectively, and you need to commit to 6 months at their side and complete all the learning, and then help with the recruitment and rollout of the study. So one example that's coming up, as we heard this morning from Beck Kim, who is a recently appointed consultant in Leeds, is the MARECA study, which has come out of the 2019-2020, just before COVID, gap analysis event by the ABS at the Royal College of Surgeons, which is a study of and a follow-up of observation study of the management of local regional recurrence and outcomes. And this study has already been adopted by the, is available for the API scheme. So if your unit has signed up to this, there's about 50 units who have expressed interest, and they're currently going through they're opened in Leeds in December, and they're currently doing the SIVs for some, they've started doing the SIVs for the other participating units. Then this might be you might be able to have a go and take part in this study and recruit patients. All the details are on the MARECA website or on the ABS website. And this very much follows the model of recruitment, prospective recruitment, entering data into REDCap. That it is research, there is some consent involved with the patient, which is great. And you can get experience of conducting research studies because there is a follow-up element in the study. Okay, so just to wrap up quickly, the main message of the talk is really, please do get involved either with the MFAC studies, which we've just heard about. In the future, hopefully you'll fund the KITS trial, which will both be portfolio adopted, hopefully, and MFAC badged, and get recognition for your research efforts. Try and take part, try and join the collaborations that are out there, the collaborative studies. There have been, this will help promote development of future PIs and collaborative research leaders. We still have a few gaps geographically, and I think this talk very much in particular, I want to have a look in your units, if you are in your regions, if there are hospitals where you are scheduled to work, and you might, there might not be any research active surgeons there. Try and see if they can join. We've had a talk this morning how to set up research as a consultant, breast research and innovation at the DGH. But please try and pester your consultants, your local consultants, to take part, and research leads to take part in these studies and become their associate principal investigator. Thank you very much.
Thanks, Tim. That was a great talk, and hopefully really informative for our trainees out there listening. So thank you so much to all of our speakers for this session. Again, no questions, and we are slightly behind time, so I'm going to move on to our submitted paper session next. And we were fortunate to have quite a few abstracts submitted for this session. So a very big thank you to everyone who did submit an abstract. And it was very difficult to narrow it down to just 4 for presentation today. Just to make you all aware, we will be marking these presentations, and I'm very pleased to announce that there will be a £75 prize for the winning presentation courtesy of the Mammary Fold. And so our first trainee presentation is from Anna Isaac, and her presentation is entitled Trimming Costs and Smoothing Curves, and that is experience with the TIGR mesh. So Anna, take it away, please.
Thanks very much. I'll just share my screen here. Going well, yeah.
Yeah, okay. I've got a blank bit. There you go. It's up. Well done.
Great. So this is basically our unit's experience using TIGR mesh for inferior pole coverage just for subpectoral implant recons. And this is in the Belfast City Hospital in Northern Ireland. So breast reconstruction is obviously an important part of the management of patients undergoing mastectomy, both therapeutic and prophylactic. Up to 70% of recons in the UK are implant-based, and the published data from iBRA suggests a UK-wide average implant rate loss of about 8%, which is higher than the sort of industry standard recommended accepted loss rate of less than 5%. Implant erosion is a major consideration for breast recon because it can lead to implant loss. So coverage is an important consideration. You can achieve this by local muscle coverage and or placement of a mesh product. So that tends to be either biological or synthetic mesh. And the biologics are acellular dermal matrix, ADMs, is how I'll refer to them during this talk. Synthetic meshes such as Tigger or T-loop have some advantages. They are cheaper generally than ADMs, and they don't require special preparation or washing prior to implantation. As has been highlighted earlier today in this meeting, there is a lack of longer term evidence on complication rates for some of these products. And so we conducted a retrospective observational study of our unit's experience with Tigger for our subpec 1-stage reconstructions. So it was data collection from our electronic patient records over a 4-year period. We had 104 patients, and some cases were bilateral, so 162 reconstructions in total. Patients were followed up at 2 weeks, 3 months, and 12 months, or more frequently if clinically indicated. And they were all just, as I said, 1-stage procedures, and they all used Tigger for subpec recons. So this table then just shows some of our complications that we had. We had 1 patient return to theatre on the index admission just for a hematoma evacuation. Our implant loss rate at 90 days was 8.6%, and total reconstruction loss, which we defined as loss of the breast envelope, was 4.3% at 90 days. A subgroup analysis identified smoking, wound infection, and the use of additional antibiotics as negative predictive factors for implant loss. There were no other factors were statistically significant for outcomes, but I think it's probably because our sample size was so small that we didn't get any statistical significance from diabetes or radiotherapy. So to put our own implant loss rate in context, as I said, the National Quality Criteria for Breast Reconstruction recommends your 90-day implant loss rate should be less than 5%. NMBRA reported 9% across the UK on average. iBRA then, when they looked at biologics, it was an average of 8% loss, and synthetics was slightly higher at 10%, which we'll come on to discuss in a wee moment. And then, as I mentioned, ours is 8.6%, so sitting fairly nicely within the national average. So looking at the literature that's available since 2013, there have been a small number of single center studies. Generally, the cases in these studies have been 49 to 62, and their implant loss rates have been reported between 0.5% and 3%. But I'd say the numbers are probably too small in isolation to carry much weight. There are, again, single center studies with other synthetic meshes such as T-loop or Surgimesh PET, and their implant rate losses, again, are up to about 8.7%, so fairly comparable to ours. As I'd mentioned a minute ago, the iBRA study, biological meshes were far and away more common. There were over 1,100 reconstructions using biologics compared to about 230 with synthetic meshes. And there was a higher rate of implant loss with synthetic rather than biologic, 10% to 8%. At first glance, that seems fairly straightforward, but there are some differences perhaps in the patient populations. There were a higher proportion of patients with a normal BMI, so less than 30, that went on to have biologic mesh reconstruction. So it may be that the two groups aren't directly comparable, and there's probably a bit of selection bias within those cases. Of the synthetic mesh assisted recons then in iBRA, there was an increasing variety of mesh products used. So there were in total 14 products. And as well, that's within the smaller subgroup of only 230 odd patients. So it's very difficult to effectively draw any comparisons between the products themselves and between biologic meshes and synthetics as a group. Synthetic meshes may be more cost effective, but there is limited long-term data for many of the products. We have shown there some of the cost analysis just using TIGR against some of the more common ADMs that we use in our unit. So the prices speak for themselves. It's a cheaper initial outlay for TIGR mesh, but that has to be balanced then against the potential costs of further clinic visits, hospitalizations, or any procedures if they have higher complication rates. Red breast syndrome, which is non-infective erythema of unclear etiology, which is only documented in the literature as associated with ADMs. It's not a feature that we think so far of any of synthetic meshes. So that is one small advantage. So in conclusion then, it was again a single centre study that we carried out, but we do think it was reasonable enough numbers. We've hopefully added to the evidence showing that TIGR mesh is safe. It has comparable implant loss rates to the national average, but it's still higher than our recommended implant rate loss. So we would like to try and improve that. May offer an economic advantage with a cheaper outlay cost. And the only statistically significant risk factors in our patient group were smoking and infection. So that's probably given us some pause for thought in which patients we're offering implant reconstruction with TIGR mesh to, particularly the modifiable risk factors such as smoking. But as has been stated many times today, we do need better quality trials for the individual meshes because the numbers are so small in individual centres using them, and we need long-term outcome data to make sure that we're delivering the best care for patients. It's just my references, and I'm happy to take any questions.
Thank you, Anna. I think I do have a couple of questions for you. So, anonymous attendee has said, I see you finished your follow-up in 2018. Why have there been no further procedures including? Have you stopped using it, and if so, why?
We haven't stopped using it, but we have swapped to mainly pre-pectoral reconstruction since 2018, and there's a separate body of work then within our unit looking at the pre-pecs. So that's simply why the data stopped at 2018.
And Tim has asked about the significant association with additional antibiotics. Was the direction of effect protective for the addition of antibiotics?
So the additional antibiotics, the majority of patients had antibiotics in the setting of documented infection, and there was a very small number that had additional antibiotics without proven infection, but still went on to lose the implant. So I think it's probably the underlying presence of infection, with the antibiotics being a surrogate marker for infection there.
Yeah. Brilliant. Thank you very much. So our next speaker then is Ritika Rampal, who is going to present a 3-month analysis of the PROM-Q study, which is a comparison of patient-reported outcome measures using the breast-Q questionnaire in pre versus subpectoral implants.
Hello, everyone. Can you see my slides?
Yes, we can, yeah.
Let me just... Okay, so hi, everyone. My name is Ritika Rampal. I am a research fellow in the Department of Breast and Reconstructive Surgery at the Leeds Teaching Hospitals. I'm going to be talking to you about a study that we've been doing in our unit in the last 2 years. It's called the PROM-Q study. And in this study, we've been looking to compare the patient-reported outcome measures using the breast-Q questionnaire in the 2 different techniques of implant-based immediate breast reconstruction, the pre-pectoral versus the subpectoral technique. So breast reconstruction has been shown to have a positive impact on patients' quality of life in general, including the patient's self-esteem, psychosocial well-being, sexual health, and their well-being in general. Immediate implant-based reconstruction is the most common breast reconstruction performed in the UK. There are 2 main types of implant-based reconstructions that are performed for patients undergoing mastectomies for both breast cancer and risk reduction. These are the pre-pectoral and the subpectoral approaches. At our unit, we have a mixed practice as to which surgical approach to use. So that's why it led us to ask this question, whether using pre-pectoral or subpectoral surgical approach really influences the clinical or the patient perceived outcomes. So we decided to conduct a prospective non-randomized longitudinal cohort study at our center. This study had all the ethical ethical approvals. We got all the ethical approvals. So we recruited all the patients, consecutive patients undergoing mastectomy, plus implant-based reconstruction from September 2019 to September 2021. We collected all the data, including patient characteristics, which included patient BMI, their age, mastectomy weight, smoking status, and whether they had the surgery for cancer versus risk reduction. We also collected data on the clinical outcomes, which included the post-operative complications like wound infections or any implant loss. For the PROMS data, we used the BreastQ questionnaire and collected the PROMS data at baseline, pre-operatively, and post-operatively at 2 weeks, 3 months, and 12 months. Our primary outcome measure for the study was to compare any differences in the patient-reported outcome measures in patients undergoing pre versus subpectoral implant-based breast reconstruction. BreastQ questionnaire is recommended by Association of Breast Surgery guidelines for oncoplastic breast surgery, which advocates any patient undergoing mastectomy followed by reconstruction should have their PROMS data measured on a routine basis. BreastQ questionnaire is ideal for that because it's a validated questionnaire which is specific for reconstructive surgery. This questionnaire scores are converted into a RASH scale from a 0 to 100. Higher score just means better patient satisfaction. It enables PROMS data to be compared between the two surgical approaches like we did, and we compared the data between pre-op data of patient expectations and also other domains like psychosocial well-being, physical well-being or level of pain, breast satisfaction or satisfaction with implants, and animation Q score. So our inclusion and exclusion criteria, we try to make the study as pragmatic as possible to introduce heterogeneity. So we included all the patients over the age of 18 who were females undergoing skin or nipple-sparing mastectomies plus implant-based reconstruction for cancer or risk reduction. We included all the patients undergoing unilateral, bilateral mastectomies, also any implant and expander-based reconstructions. And to make the study more ethical, we included everyone who was able to read and understand the questionnaire in English. Our exclusion criteria, we excluded every patient who was male and transgender. Anyone who was having autologous or delayed reconstruction was also excluded. And anyone who had mastectomy without reconstruction was also excluded. And anyone who wasn't able to provide informed consent or had cognitive impairment was also excluded. So we were able to recruit 76 patients, 44 in the prepectoral group versus 32 in the subpectoral group. The patient characteristics in general were quite comparable. So patient age was, these values are in median, was 43.5 in the prepectoral group versus 49 in the subpectoral group. The BMI was 24.5 in the prepectoral group versus 26.8 in the subpectoral group. The mastectomy weight was 368.5 in prepectoral group versus 466 in the subpectoral group. Smoking rate was 9% in the prepectoral versus 12.5% in the subpectoral group. The only statistically significant difference we found was that in prepectoral group, most patients, higher patient numbers had surgery for cancer versus risk reduction. So that was the only statistically significant difference that we found. In terms of the clinical outcomes, again, they were really comparable in both the patient cohort. So 13.6% of the prepectoral patients had complication rates and 9.4 in the subpectoral group. And the overall implant loss rate was 3.9% at 3 months, with a higher loss rate of 6.8 in the prepectoral group versus none in the subpectoral group, and this was at 3 months. For the whole of the cohort, we also looked at any unplanned readmissions and unplanned reoperation, which was 5.2% and 3.9% at 3 months respectively. In terms of the PROM-Q scores, so in terms of the breast satisfaction score at 3 months, it was 64 in the prepectoral group versus 57.5 in the subpectoral group with a p-value of 0.3. In terms of the animation Q-score, it was 74.5 in the prepectoral group and 73 in the subpectoral group with a P of 0.17. And the psychosocial well-being at 3 months was 61 in the prepectoral group versus 56 in the subpectoral group with a P of 0.62. The physical well-being was looked at 2 weeks, which was 47.5 in the prepectoral group versus 45 in the subpectoral group with a P of 0.39. And similar results were found at 3 months with 70 in the prepectoral group versus 76 in the subpectoral group with a P of 0.49. This was certainly quite surprising, as you would expect the scores to be much lower in the subpectoral group because of the extensive dissection and the partial division of the pectoral muscles, but this was not the case in our cohort. So far the study demonstrates, like we said before, fairly equivalent clinical and patient perceived outcomes between the two surgical techniques of IBR. Obviously, we will collect the longer PROMS data at 12 months in this September to further evaluate if there were any differences in the patient perceived outcomes and the clinical outcomes between the two surgical techniques. But like I said before, the numbers for this study were quite small as it was a single-centered study. So this study further advocates a need to conduct a multi-center RCT like the BEST-BRA study, which Ms. Potter said, to determine what the optimal surgical approach is. And that's it from me. I'll take any questions.
Thank you. Sorry, I'm having trouble with my buttons on my screen. Kit, do you want to ask that live?
Hi, Ritika, that was great. It's really interesting. Are you as a centre recruiting to BEST-BRA?
Yes, we are. So we forgot to say, so we have expressed our interest in from Leeds in BEST-BRA study. So we will be recruiting for that soon.
Brilliant. Thank you.
Excellent talk. Well done, Ritika. If there aren't any more questions, we'll move on to the next presenter. So the next speaker is Arjuna Brody, who is presenting on therapeutic mammoplasty and its associations with long-term side effects from breast radiotherapy. Arjuna, do you want to produce? Fantastic, thank you.
Yeah. Yes, good afternoon. So I'm Arjuna, I'm a core surgical trainee in Leicester. The title of my project is Therapeutic Mammoplasty is associated with fewer long-term side effects from breast radiotherapy. So breast conserving surgery followed by adjuvant radiotherapy is standard treatment for breast cancer in selected patients with similar long-term survival rates compared to mastectomy. However, in breast conserving surgery, if the estimated percentage of breast volume excised is greater than 10%, this is associated with significantly reduced satisfaction with breast appearance. In breast radiotherapy trial cohorts, larger breast size and volume are consistent predictors of significant radiotherapy side effects such as atrophy and induration. Therapeutic mammoplasty extends the role of breast conserving surgery by combining wide local excision of the cancer with breast reduction and mastopexy techniques. It is hypothesized that therapeutic mammoplasty can achieve more acceptable outcomes than standard breast conserving surgery by reducing the adverse effects of radiotherapy in women with larger breasts or those with greater than 10% breast volume excised by reshaping the breast and reducing breast volume. The aim of this study was to determine the effect of therapeutic mammoplasty using level 2 oncoplastic techniques on the incidence of early and long-term radiotherapy side effects. The methods, breast cancer patients were recruited prospectively into the International Multicenter Requite cohort study at the University Hospitals of Leicester between 2014 and 2016, and toxicity was scored at baseline, following radiotherapy, and at 2-year follow-up. Initially, we had 349 patients included in the study. However, patients with baseline toxicities were excluded, leaving 346 cases. These patients had photos taken and toxicity scored at baseline. And after radiotherapy, data was collected regarding toxicity from 339 patients. And at 2-year follow-up, data was collected from 238 patients, meaning there was a 30% loss to follow-up. The radiotherapy endpoints included early side effects, which were 1 to 2 days either side of the end date of the radiotherapy, and included dermatitis, ulceration, and edema, and late side effects, which was collected at 2 years, which included breast atrophy, nipple retraction, breast edema, induration, and telangiectasia. Breast volume reduction greater than 10%, total specimen weight, and therapeutic mammoplasty were investigated in association with toxicity endpoints and multivariable regression models adjusted for patient treatment covariates. And I obtained data on specimen weights for all the 346 patients from the hospital electronic medical records, and details on the surgery from the patient notes. So looking at the characteristics of the two cohorts, there were 78 patients in the therapeutic mammoplasty cohort and 268 in the breast conserving surgery or BCS group. Therapeutic mammoplasty, the cohort were statistically younger with a median age of 54 compared to 61 with a p-value of 0.002. The tumour size was also larger for the mammoplasty cohort with a median size of 16 millimeters compared to 13 millimeters and a p-value of 0.006. And as expected, the excision weight was larger for the therapeutic mammoplasty cohort with a median total excision weight of 64 grams compared to 41 grams for the BCS cohort with a p-value of less than 0.001. The estimated pre-op breast volume was larger for the mammoplasty cohort, 780 cc compared to 710 cc. However, this was not a statistically significant difference. The proportion of patients with greater than 10% breast volume reduction of pre-op volume was 44.8% for the mammoplasty cohort compared to 17.9% of the BCS cohort, which was statistically significant. And the mammoplasty group were also more likely to receive radiotherapy to the supraclavicular fossa with a percentage of 14.1% compared to 5.6% for the BCS cohort. Also, the mammoplasty cohort, 5.2% had diabetes, 38.5% were smokers or previous smokers. This was compared to 9.3% and 50% respectively for the BCS cohort. However, neither of these differences were statistically significant. So now moving on to the looking at the toxicities. So the early toxicities included edema, ulceration, and dermatitis, and these are roughly even between the two cohorts. But for the late toxicity, late atrophy grade 2 or above was 22.6% for the mammoplasty cohort and 19.6% for the BCS cohort. Late telangiectasia grade 1 or above was 3.6% for the mammoplasty cohort compared to 14.8%. And late induration tumour bed grade 1 or greater was 12.5% for the mammoplasty compared to 26.5% for the BCS cohort. And late induration outside the tumour bed was 5.4% compared to 14.8% for the BCS cohort. So here we have the results of the multivariable logistic regression for induration tumour bed grade 1 or above. And here, so we found that mammoplasty and, interestingly, smoking were protective. So mammoplasty odds ratio was 0.12 and smoking odds ratio was 0.41. Also, total specimen weight, BMI, and radiotherapy to supraclavicular fossa were statistically significant factors that increased the risk of induration of the tumour bed. Moving on to look at induration outside the tumour bed, grade 1 or above, it was mammoplasty, but not specimen weight that was associated with a reduced induration outside the tumour bed with an odds ratio of 0.19 and p-value of 0.03. This is important because it's mammoplasty which reshapes the breast and not the size reduction which reduces radiotherapy dose inhomogeneity in the breast. Looking at telangiectasia grade 1 or above, similarly, it was mammoplasty that was also associated with a reduced incidence with an odds ratio of 0.12 and p-value of 0.02. Also, radiotherapy to the supraclavicular fossa was associated with an increased risk. So in conclusion, at 2 years post-radiotherapy, it was therapeutic mammoplasty, but not resection weight, that was significantly associated with a reduced incidence of grade 1 or above induration inside and outside the tumor bed, as well as telangiectasia grade 1 or above. This implies toxicity may be affected not by reducing the overall target volume, but reshaping the breast, which is likely to reduce dose inhomogeneity. The incidence of breast atrophy was not associated with therapeutic mammoplasty or specimen weight. However, patients entered the study post-operatively and pre-radiotherapy, which may have given a grade greater than 0 for patients undergoing therapeutic mammoplasty. And neither specimen weight nor therapeutic mammoplasty had any effect on early toxicities, confirming findings from a previous publication, albeit with a lower proportion of patients who had undergone therapeutic mammoplasty. That's my acknowledgements. Thank you for listening.
Thank you, Arjuna. That's really interesting. Does anyone have any questions? Just going to check the question board because I missed one last time. No? Okay. I think we'll move on for now then. Thank you very much. So our next speaker is Shaisa Zafar, who is going to present on surgical outcomes of ambulatory chest wall perforator flaps for breast reconstruction.
Hello. Hi. I'm trying to share my screen if I can. Is it shared or not? I had some issues with sharing my screen yesterday when I was trying it. So maybe I can use your backup presentation.
Yeah, bear with me.
Yeah.
Lena, do you have the slides pulled up?
I'm just going to share my screen now.
Thank you.
Oh, thank you very much. Okay. Can I flip the slides or you have to do it for me? I'm so sorry for bothering you like that.
I think you'll have to say next.
Okay. Thank you very much. Okay. Thank you very much for the organizing committee to allow me to present my work in this meeting. I'm Dr. Shaisa Zafar. Initially, I used to work as assistant professor of surgery in Pakistan Institute of Medical Sciences, Islamabad. And now I'm an international surgical training fellow of Royal College of Surgeons in oncoplastic breast surgery in City Hospital, Birmingham. And this work has been supervised by my two consultants, Mrs. Geeta Shetty and Ms. Melissa Tan. And it is about the surgical outcomes of ambulatory chest wall perforator flaps in breast reconstruction. Next. So chest wall perforator flaps after breast conserving surgery are level 3 oncoplastic breast surgery procedures. They're effective enough to reduce the deformity and asymmetry and to avoid mastectomy and contralateral surgery. Next. These are a few pictures showing the noticeable deformity after simple wide local excision. Next. Smaller breast. Next, please. Smaller breast. Next. And small to medium-sized breast, and when the tumor to breast ratio is very small. Next. Complex oncoplastic procedures are usually performed as, yes, next please. Sorry. Next slide, please. So complex oncoplastic breast surgeries are performed as inpatient stay procedures in routine, but there is an evidence that enhanced recovery after surgery can, if the protocols are used according to the enhanced recovery after surgery, most of the autologous and implant-based reconstructions can be performed as day case procedures. Next, in iBRA-Net, most of the breast cancer work, including the level 2 and 3 oncoplastic procedures, are performed in ambulatory settings. And that is why we decided to see if chest wall perforator flaps after breast reconstruction, when performed in single stage, can be done in an ambulatory pathway. So the primary aim of our study was to determine the same day discharge rate and less than 23 hours post-surgery discharge rate. And the secondary outcome was to be determined by re-excision rate, 30 days post-surgery complication rate, and the rate of unplanned return to theater. Next. So we collected our data retrospectively from a prospectively maintained logbooks of the surgeons and hospital database. The study involved a cohort of patients who had chest wall perforator flap-based breast reconstruction between July 2019 to February 2022. Next. We had a total number of 126 patients who had chest wall perforator flap-based reconstruction, but 2 of them, they had salvage procedures for implants, so they were excluded from the study. Another 3 who had mastectomy and chest wall perforator flap-based complete breast reconstructions were also excluded from the study. And then 1 patient who had chest wall perforator flap-based reconstruction after breast conserving surgery, but in 2 stages, were also excluded from the study. Next. So we were left with 120 patients in total. So this is the normal pathway of our ambulatory surgery after diagnosis, and MDT discussion patients are usually seen in result clinic. And if they have more than 1 surgical options, then they are seen in the oncoplastic clinic by our oncoplastic surgeons, and all options are discussed with them. Then they are given normally 1 week time to reflect upon all the options and come up with a decision and follow-up clinic. And there we get their pre-op medical photography done, and we record our pre-op part of the data of prompts in that clinic. Next is the pre-admission clinic, when all the information about the ambulatory pathway is given to the patient. On the day of surgery, the operation is performed under general anesthesia, and then depending upon the surgeon's practices, local anesthetic or pectoral blocks are used to enhance the recovery after surgery and encourage an early discharge after surgery. And if we have used drain or any other concern about the wound, then we call the patient in a week time. Otherwise, in 3 to 4 weeks time, when the biopsy results are available, we see the patient in result clinic and get their post-op medical photography done. Normally, patients have a follow-up at 3 and 6 months time in oncoplastic clinic, in addition to the patient-initiated follow-up program and 5-year MDT before they are discharged from their treatment for cancer. Next. So our 120 patients, the median age was 53 years. Majority of our patients had cup sizes of B, C, and D, which are reflective of UK women bra sizes. 10.6% patients had neoadjuvant chemotherapy, and 15.6% patients had previous breast conserving surgeries, but had involved margins and were candidate for excision of margins with chest wall perforator flap-based reconstruction. Next. 15% of patients had 1 or more risk factors. Next. A third of patients had 1 or more comorbidities. Next. So 60% of our patients had DCIS with or without invasive disease. Next. Is there a slide above this? Sorry. Yeah, that's fine. Okay. So this chart shows that the tumors were almost every quadrant of the breast have been addressed by this surgery, even in the upper inner quadrant, 6.7%, and multifocal disease at 28.3%. Next. The pre-op median tumor size on imaging was 37 millimeter, but 26.7% cases had tumor sizes of 50 millimeter and above. Next. Most common chest wall perforator flap was harvested on lateral intercostal artery perforator flap. Next, please. 24.2% patients had required axillary node clearance at the same time. Next. We used trainer in majority of our patients. Next. Median weight of the specimen was 114 grams. Next. And median histology size of the tumor was 39 millimeter. Now, all these were the demographics of the patients and disease, and now the primary outcomes. So looking at the primary outcomes, 97% of patients were discharged within 23 hours of surgery, and 21.7% patients could go home same day. Next. Our re-excision rate was 11.7%. Next. Majority of our patients, 87.5%, did not have any complications. Some minor complications like delayed wound healing and seroma were there. Major complications were return to theater and pulmonary embolism. Next. 5 patients had unplanned return to theater. 3 had progressive hematoma. 1 had a delayed wound healing due to infection. Another had a delayed wound healing due to fat necrosis. Next. This is an intraoperative picture of one of our patients in which the chest wall perforator flap was harvested on lateral intercostal and anterior intercostal vessels both. Next. These perforator dissected, and finally the flap set in. Next. This was her pre-op picture and 5 months and 3 months post-op pictures, the same patient. Next. This is another patient who had central wide local excisions, and we used an anterior intercostal artery perforator flap with a skin paddle. Next. This was the pre-op picture of the same patient, and then 2 weeks post-op, and then 4 months post-op, which was 1 month post-radiotherapy as well. Yeah, next. These are our markings and some activities in theater with a lateral intercostal artery perforator flap. Next. The same patients after 2 weeks. Patients. Next, please. Another MICAP with a small breast, but a good BMI to give us enough tissue to replace it. Next. Another wide local excision and axillary node clearance with LICAP and a skin paddle. And another MICAP. So we concluded that 97% of the patients, ambulatory surgery could be done when we were doing a chest wall perforator flap based breast reconstruction, partial breast reconstruction after breast conserving surgery. Our re-excision rate was 11.7%, and our 30 days post-surgery complication rate was 12.5%. Now that we have our data and we are further maintaining our data, we intend to look into the short and long-term outcomes, including disease-free survival and overall survival. And we are also maintaining our data about the patient-reported outcomes in pre-operative setting and in post-operative settings at 3 to 6 months' time. And hopefully we'll be coming up with those projects as well. Next, these are references. Next. 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 Thank you. And any questions?
Thank you very much. Some lovely data there. Has anyone got any questions? I can't see any at the moment. So I'm going to move on then, if that's all right. So our final speaker of the day is Mitali Das, who is going to talk to us about her experience of setting up an out-of-programme for research period. Mitali is a research registrar in breast surgery from the KSS Deanery and currently out of programme studying in Liverpool, I believe, and is one of our MFAC committee members. So Mitali, if you'd like to take it away, please.
Thank you very much, Jenna, for the introduction. I think you've already taken some words out of my first slide for me, but I'm going to go with my script anyway. So hello, everyone. My name is Mitali Das. I'm a ST5 General Surgery Registrar with an interest in breast and current member of the MFAC committee. The aim of this presentation is to give some advice and points to consider from my personal experience when applying for a research degree if you are not already on an academic pathway, but wanted to consider going out of programme. I'm in my second year of my PhD at the University of Liverpool. This is an unfunded project that my supervisor and I had to secure funding for. I'm already, as Jenna said, a KSS trainee originally, so had moved deaneries for this. One of the first things I would think about is, why do you actually want to do this? It is a significant amount of time out of programme. Do you genuinely have an interest in furthering knowledge in your area of interest, or is this a way of enhancing your CV for CCT? The curriculum has changed recently and the research requirements have eased. Going out of programme isn't the only answer to achieve the CCT requirements anymore, although that is what traditionally has been done. What do you want from your career long term? Do you want to be a consultant that has some SPAs for research and be a research supervisor? Which deanery do you want to do this in? I had been in the same deanery since F1. Senior registrars had said to me, it is good to experience other deaneries throughout training, which is something I took on board when I looked for my degree. A lot of advanced planning is required. It can take up to 2 years to plan this, and you need a solid project to justify going out of programme, as well as paperwork to back up your request. I'll go into this a bit later. It is also worth considering when in your training you want to do this. The general advice I got was to be on-call competent, i.e. at least ST5. So if you do need extra funding, you can do that by doing on-calls. Of course, surgical training varies, and you may not feel like that even at ST5. I know several people who have gone out of programme sooner, but it is generally advised by TPDs not to do it too late, i.e. after ST6 or 7, you need to focus on your surgical skills of your subspecialty. This slide shows you the main things I will go through in this talk that you would need to consider. If you have any other questions at the end of this, I've left my contact details for you. Again, this is what I've learned from my personal experience, and not all may apply to you. So where and how do you even start to look into this? The first step would be to approach your educational supervisor. That's what I did. Chances are, even if they didn't do research themselves, they will have been around long enough to know people who have done. They will know who is research active, and maybe they are themselves. It is also worth speaking to senior reggers currently in research or have done research to ask how they went about finding their project. Someone might be finishing their time out of programme, but their work might need to be carried on. There are also some resources online that I've put on this slide that you can look at. It's also worth thinking about which units in your deanery facilitate research. This is where your AAS comes in handy and can help reach out to people for you. What local university would your project be affiliated with? What resources do they have? There could be department leads you could approach directly. Do you want to do an MD or a PhD? Generally, an MD is 2 years and a PhD is 3. It's also worth considering that the research work doesn't take up the full 2 or 3 years, so you can write up your thesis and do your viva before your return to programme. It isn't always possible, but that's something worth discussing with your potential project supervisor. It's going to be tough going back into training after a long time out, trying to find your feet again as a surgical reg, but also trying to write up your thesis and do your viva at the same time. What kind of project do you want to do? Do you like the idea of being back in a lab using pipettes, performing cell culture, or would you rather do something more clinical? Both have their merits and contribute towards advancing knowledge, but again, it's a long time out of programme, so if you don't enjoy the process, you'll get bored. Now to funding. This is probably the biggest hurdle if you pursue an unfunded project. My PhD is fully funded for 3 years, but it took me time to achieve this. I started applying for funding while still in training. It took me 18 months to secure a full salary. My first 9 months out of programme was spent doing clinical sessions and using savings, and I also had a supportive husband. My supervisor had also obtained a small grant for consumables to start the lab work, but it was my salary that was the key issue. My best advice would be to apply for a funded degree. This is itself a competitive process, but removes the stress of funding applications. Funding is also scarce right now. COVID and Brexit have been a major hindrance to research funding. Things are appearing to improve, however, and funding bodies appear to be reopening the windows up for applications. On this slide, I've put a selection of funding bodies to look to. If you do need to go through this process, keep an eye regularly on opening and closing dates and how many times in the year they have windows open. Often also, many research posts are advertised as funded for a year, and the supervisor may expect you to apply for further funding to keep the project going. It also looks good on your CV to show that you can secure a grant. Funding applications take time. There is a lot of paperwork involved and usually needs several revisions prior to submission. You need to seek out people who have had successful applications with the body you are applying to. For example, MRC usually publishes a list, so you may find names of people at your proposed university that you can contact. The RCS also has a list of previous fellows on their website. It is a very competitive process. Remember, you are not just competing with other doctors for some of them, but a whole world of scientists. You need to have a key central research question, and your grant application needs to show that you can set out what you aim to achieve in the time the grant is being provided for. So, for example, if you're applying for a one-year fellowship, the work you are proposing should be completed in that time. Grant providers would expect updates and reports. Your supervisory team are instrumental in this. If one of your supervisors is clinical, they will know of people that have had successful grants from surgical bodies such as the RCS, and will know the societies that award grants such as the ABS does for breast. If one of your supervisors is a scientist, they will also have knowledge of other scientific bodies you can apply to and who has been successful. As I've just alluded to, your supervisory team is also key to how successful your time at a program will be. I cannot stress how important they are. I'm very fortunate to say I have had an extremely supportive supervisory team who helped me with my grant applications and also supported me getting varied clinical experience with the breast team to maintain some clinical skills. 3 out of my 4 supervisors are clinicians, 1 surgeon, 1 histopathologist, and 1 oncologist. My 4th supervisor is a postdoc fellow who has trained me in the lab work. When seeking out a project, you also need to find out who is going to be supporting you and how. Be clear in what you need and ensure they can help you with this. Who is going to teach you how to do the experiments? How are you going to maintain any clinical skills, and who is your contact for that? Who is going to read over your write-ups, and are you going to be supported in publishing papers? It is worth remembering you can set up an MD or PhD in publication where your individual chapters can be published, and then the same content makes up your thesis, so you're not writing up twice. Not all universities will allow research degrees to follow this format, but it is definitely worth asking the question. Finally, there is some paperwork required by your deanery to apply to go out of programme for research. This needs to be signed off by your AAS, your TPD, and finally the DME. They need to see an outline of the project, who your PI supervisory team is, and how they will be supporting you. You need a solid justification for being released from training. Go on your deanery's website and download the forms. I hope that's been insightful for you, and here are my take-home messages. Start early. Choose your supervisory team carefully. It is not a holiday. Don't burden yourself with too much clinical work. Getting funding is competitive. Be mentally prepared for a lot of rejections. I hope that's been insightful for you. If you have any other questions, please feel free to email me, and good luck.
Thank you so much, Mitali. I'm sure that was really useful for all of those trainees out there that are listening. If anyone has any questions that they want to ask Mitali or any of our speakers from this afternoon, if you pop it on the chat now or in the Q&A section, we can put them out to the speakers. We still have a few minutes left of this afternoon session, and I would just like to say a very, very big thank you to all of the speakers and everyone that's helped arrange the day today, especially at the ABS office, who've been working tirelessly behind the scenes and have set everyone up as panelists. And also for this afternoon to the MFAC committee, who have been scoring all of the trainee submitted presentations this afternoon as well. Tim, I can see you've got your hand up.
Yeah, not so much as a question as a comment. Just for the trainees that have, especially those who listening to Mitali's presentation just now, we are in the process of revamping the ABS research pages and updating it with some relevant material for research interested trainees. So please have a look at the ABS website and click on the research pages, and then you get a link to the Mammary Fold Academic Committee, or you can go through the Mammary Fold section, you'll get a link to the research pages, and all that. And Mitali's talk will go on there, and we are planning to do a webinar series as well over the next sort of 18 months, which will be joined by more senior researchers, consultants, PIs, and trainees, people who have done research, people who are doing research at the moment, just to get to get people, give people a sort of head start on what they need if they're interested in research as a breast surgical trainee. So yeah, have a look at the website and you'll find it there.
Thanks, Tim. And I think somebody's helpfully put some of the links to both the MFAC web pages in the chat, and also the Twitter handle as well, because we regularly post adverts and opportunities on there. So I would like to finish this afternoon off by announcing the winner of the trainee prize. So can I say, and can everyone join me in saying a big congratulations to Anna Isaac, who was the top scoring presenter today. So well done.
Very much. That's lovely.
Excellent. I will be in contact with you after the event this afternoon. So thank you very much to all of our speakers for submitting their presentations, and also thank you to Shelley Potter and everyone else in the iBRA-Net committee for inviting us to collaborate with them for what has been a really, really enjoyable and interesting academic and research day. So thank you, Shelley. I don't know whether you want to pop back on and just say a couple of words to help me close.
Oh, yeah, thank you, Jenna. I thought that was a fabulous afternoon. Those training presentations were a really good quality, and I think it was a really good afternoon, and I hope that you all really enjoyed it, and I hope we can do some more joint things in the future.
Yeah, I couldn't agree more. I'm very proud to have been a part of it. So thank you, everybody, for your support. I couldn't have done it without all of you.
No, it's been brilliant, and thank you, Jenna, for organising the MFAC bit. I think it's worked really well today, and thank you all, everyone, for coming, and have a lovely rest of the day.
Good. And here's to some face-to-face meetings in the future.
Yes, definitely. The next one is definitely face-to-face, and there will be cake.
It sounds perfect.
Congratulations, Anna. Well done.
Thank you.
Bye-bye, everybody.
Bye-bye.